Hello, good morning. We want to start the program. Can we have everybody come in? Those at the back, can we start filling the front rows first? So that those who come later will occupy the back. Let's all fill the front rows. Please just make sure there is no empty seat in front of you. Just make sure there is no empty seat in front of you. Let me take the opportunity to welcome all of you to our 35th Annual General Congress. That is about starting now. We want to be on time because we have a lot of things to do today. And so we'll call on Dr. Helen Rieko, who is our executive member female, to give us the opening prayer. Please let us welcome her with a round of applause.
Good morning, everyone. Good morning. Okay, please, you are all welcome. Shall we bow down our heads in prayer? Dear Lord, we are most grateful for the gift of this morning. We thank you for our lives, we thank you for our health, and we thank you for the strength to be able to make it to this gathering. Lord, as we have converged here to begin the first day of our 3-day Congress, we ask that you come and take center stage, steer all affairs, and make sure or guide us so that all our deliberations will be impactful and all our activities will be a success. We also pray for those of our number who are still on their way here. Bring them here safely so that they will come and join this wonderful fraternity and be able to benefit all that we have planned. These and many other blessings have we asked. In your Son's mighty name have we prayed with thanksgiving. Amen.
Thank you, Dr. Rieko. I think we can do it better for her. This morning we are starting our Congress with our scientific sessions or meetings where we are going to have a lot of discussions on the theme for our Congress. And so we'll encourage everybody to participate fully in all our activities, especially all dentists. Every part of our discussions of the days are very, very important for us. So please make sure that you stay in throughout. You can also call our colleagues who are yet to be here. Just give them notice that we have started and they should dash here as quickly as we can. In course of time, I will share with us the program outline for today. We want to apologize that we have a little hitch in giving us the programs now, but we'll be receiving the outline in a short while. So just bear with us. I'll moderate from here with what I have and I'll keep you updated. On that note, every Congress is okay, I'm informed that an electronic version of the program is on the Dental Hub. So as many of us that are there can pick it up from there for now. But we're going to get us our copies and stuff shortly. This 35th Annual General Congress happening here in Accra. And there is a wonderful team that have organized this program for us. And it is just right that when we are in the city, our colleagues in the city must welcome us into the city. So without much ado, we want to call on the chairperson of the local organizing committee of our 35th Annual General Congress to welcome us formally. Let's welcome Dr. Beryl Nate, please.
Distinguished colleagues, esteemed speakers, honored guests, ladies and gentlemen, good morning. It is both a privilege and a great pleasure on behalf of the local organizing committee to warmly welcome you to the 35th Annual General Congress of the Ghana Dental Association. Whether you have traveled from across Ghana or beyond our borders, whether you are with us here in person or joining virtually, we are delighted to have you with us. To our online participants, please know that distance does not diminish your presence. You are very much a part of this Congress, and we warmly welcome you. This year's theme, Ending Dental Quackery, Restoring Trust in Dental Care, speaks to a responsibility that belongs to all of us. Trust is the foundation of every patient's relationship, and preserving that trust is essential to the integrity, credibility, and future of our profession. Over the next 3 days, we have the opportunity not only to reflect on the challenges before us, but also to share ideas, strengthen partnerships, and chart a path that advances safe, ethical, and quality oral health care for all. We are privileged to host distinguished speakers and experts, both local and continental, whose knowledge and experience will enrich our discussions and inspire us towards meaningful action. But beyond the scientific sessions and business meetings, Congress is also about fellowship. It's about reconnecting with colleagues and friends, forging new relationships, exchanging ideas, mentoring the next generation, and celebrating the profession that unites us. As a committee, we have carefully and lovingly planned every aspect of this Congress, from the scientific sessions and exhibitions to the excursion, the gala dinner and awards nights, with one aim: to provide an experience that is enriching, refreshing, and memorable. Above all, we give thanks to Almighty God for His grace, mercy, and faithfulness. We are grateful for journey mercies and for the blessings of gathering once again in good health and in peace. We are especially thankful for the beautiful weather and pleasant atmosphere He has granted us, and we pray that our time together will be productive, enjoyable, and memorable. Over the next few days, I encourage you to participate actively, engage freely, renew old friendships, make new connections, share generously, learn continuously, and above all, enjoy the experience. To our speakers, sponsors, exhibitors, and every member who has contributed in diverse ways to making this Congress possible, we extend our sincere appreciation. Your support and commitment are deeply valued. Ladies and gentlemen, welcome to the 35th Annual General Congress of the Ghana Dental Association. May our deliberations be fruitful, our fellowship enriching, and our time together truly memorable. Thank you, and God bless you.
Thank you, Madam Chairperson, for thanking us and welcoming us to the city. I must say that it's wonderful. But when I got in here, I can attest to the good job that the LOC has done. I think the LOC deserves a round of applause. Let's give it out to them. All right. We acknowledge all our sponsors and partners, and we welcome all our exhibitors. We know that it's going to be a fruitful discussion. Before we get to the meat of the theme for this Congress, we will have a teaser presentation to prepare ourselves to get into the scientific session. For the first round of presentations, we are going to have 3 presentations. One will be a presentation on practical digital dental implantology using surgical guides. And then we're going to have a presentation from Mega Life, and then a presentation from Crown Health, in that order. So at this time, I'll call on, I don't know whether to add Mr. to the name, because I'm told when you have Nana, you don't add Mr. So I don't know whether to say Mr. Nana. But if I'm permitted, then let's welcome Nana Echampong to give us the first presentation on practical digital dental implantology using surgical guides. It's going to be a 20 minutes presentation. Let's welcome Nana to the stage.
Thank you very much. Good morning, everyone. Today is a surreal day for me. Before I start, I'll say I bumped into my old classmate that I saw 37 years ago before we all left to the UK. And so the conversation that we had in Kolebu 37 years ago, we revisited it and we're continuing. So Dr. Eduako, God bless you. And God bless GDA and the organizing committee. They've done a really brilliant job and choosing a topic that is very close to my heart, dental quackery. But let's whiz through implantology today. And if you don't place implants, I can assure you, you will be tempted after this presentation. So the photo you see there is my practice in the UK, and not very far from there, there's a hairdresser. And one of my patients came one day and said, look, how much do you charge for bleaching? Because the lady across the road is charging less. And dental quackery is everywhere. It's everywhere. So that topic is really, really important today. And that's my surgery, and if I'm not there, I'm actually here in Ghana doing implants and interacting with my colleagues. Okay, so let's go through the options that we all know. Denture, bridge, implant, do nothing as the default option of replacing a missing tooth. The outline for today is going through the normal method that we all know, and then graduating to something different. And mind you, I'm a creature of habit. I never change. So if I've changed to digital, you can change as well. It cuts down your surgery time by 50%. So what we want to do with implantology is you want to mimic the position of the God-given tooth. You just want to place where the tooth was before. So let's go through the conventional method of what I used to do. But before we start, I want you to have a look at this photo. Make a mental note of it, of this photo. So, this patient, a wife of a diplomat I treated, and her concern was upper left 4 missing. She had aesthetic issues with that. That's the lower arch. So perfectly, an okay mouth, very good mouth. That is the OPG. You can see the gap there. And the normal way was to just raise a flap and place an implant. So you can see the buccal concavity there. You can see that there's a depression there, which is normal. So I raise a flap, and then I put an indicator in there just to see my orientation, whether I'm right in the middle. So this is just eyeballing it. And I proceeded to finish it off. You can see the implant going in. This is a Neos implant, and with blood actually rising up the implant before the implant gets into the osteotomy site. So you can see it's really hydrophilic. And that's the implant placed. Sutures dissolvable placed. That's the radiograph. After 3 months, that's what we see. That is normal. The gum architecture is good. That's the tooth. Post-operative radiograph. And that's where we are. Normal stuff. We go a little bit advanced. You can see the upper left one is suffering a bit. It's extruded. The radiographs show post-retained crown there. And then tooth broke off. Treatment of choice here is to extract. We did that. Waited for about 3 months. There's also a concavity there. You can see it there. That's what happens when you take a tooth out. It's just buccal concavity. But that's the x-ray I have. I don't know anymore. All I know is a little bit of radiolucency here. But I don't know what's happening underneath here because I only have a two-dimensional photo. I open up and this is what I get. Surprise, surprise. At this point, you have to have a bone graft material. If you don't have it, the game is over. So bone graft, I normally use a xenograft, cow bone called bios, stitched up, and that's the end result. So you can see the bone has been built up a little bit here with the cow bone. A graft material is what every implantologist must have, just in case. But I did not know what I was going to meet on that time. So that's the finished work. And that's just a synopsis of the bone graft material. The best bone is the autogenous bone. We have the allograft, which is the same species, different individual, and the xenograft obtained from other species. The alloplast is synthetic. For religious reasons, someone may not want the first three. Right. This gentleman, a Japanese CEO, talked about why things happen. Why did this break down? Why wasn't that sorted out? So I asked myself, after doing this for many years, surely there must be something that will help us work quicker, effectively, safely, better outcomes for the patient. So that is Prince William there talking to reporters when they asked him how many kids has he got. And making that thing gesture, as you know, in certain parts of the world is being very rude. And so this is actually what he meant. 3. So that is the view, the other view of what he was saying. But if you looked at it from the first one, you would think that he's making a rude gesture. And that's what digital implantology is about. 3D representation of what you can see. And the CBCT is the first tool that you need. Now, I know we have a lot of those machines here in Ghana, and we can access them easily. So it gives us 3 planes: the cutting in front, the cutting in the middle, and the cutting at the top. And the computer arranges all this nicely so you can see what's going on. So with this patient, this initial application of CBCT in its partial format, the patient is made a denture, and an x-ray is taken with that denture in place. So you can see with the restorative dentist here where the future tooth is going to be. You can see the root that is retained. He fell off his bike, that man. That root is there in that view, in that coronal view. But you can see that there in that sort of OPG view. And the top view, probably there. So we make a surgical guide out of it, just like you're making a mouth guard, and the position of the teeth are predicted. Flap is raised, and those are indicators just to tell me exactly where I am. Okay, put that there, check. It's a little tedious, this one. Stitch up, graft, impression, and then the final work. Dr. Duako, I think this is for you, Dennis Turner, who says that the position of the contact point will determine whether you have the papillae rising to fill the gap. And if the contact point is less than 5 millimeters from the crest of the bone, then the gum will rise. And this is how it changes as you get along. If it's more than 5, then the 60, you can see it's about 56%. So, and that's the final result. Now, this is the quick one, and this is what everyone I would recommend to. This is a photo of an implant that is placed, and you can see the lingual concavity is close by. And if you do it by 2 dimension, you wouldn't know that you are going to hit the lingual concavity. And you can have slow bleeding overnight, and in the morning, it will be called that your patient has got some sublingual hematoma. So it is safe to have a CBCT. So this patient, she has a cracked tooth. You can see the cracked tooth there. I extracted the tooth. That's the full mouth. And the workflow. Remember, plan. So CBCT is here in Ghana. Intraoral scan, everybody uses them. And then the design, someone sits in the laboratory and puts the implant in it virtually. And then you make a 3D printer of it and make a guide, put it back in the patient's mouth, and you are ready to place the implant. So that's the CBCT of the patient. You can see the measurements on there. You can see the intraoral scanner ready, and it's planned in someone's bedroom or someone's study. That's how it's going to be like. The implant has been placed in there virtually. This is a cloned patient. All the measurements is taken into consideration. You don't have to think about it, eyeballing it. That is the guide that has been made from that. This is the sweet bit. Ostem implants. I have no shares in it, but I just want to share how they've been good to me in terms of placing implants. It's a normal implant there, and this is the one guide. You have a guide that you place the implant through. So if you can see, that is the twist drill, but there's a shoulder there, and the shoulder stops on the guide. So you can't go any further. It's very safe. That is the implant kit. Again, you can see the shoulder of all the implants. So if you're drilling 7 millimeter, it's 7. 8.5 is 8.5. You don't have to have markings on it to just count which one is 7 or 8. Everyone has its measurement. Okay. Safety and accuracy, it goes through the guide, and then the guide fits in the mouth like that. You place. This is how you do it. That is a scalpel. It's a round scalpel, goes through the guide and takes the gum away like this. And that's your surgical site. And that's the implant ready to be fitted. You can see the yellow markings will tell you where to stop when the implant is properly buried like that. And that is the healing abutment over it. And this is, you can see I'm traveling at a fast pace, but that is how it is in the chair. It's very, very, very straightforward. 3 months later, look at the soft tissue. And then you take an intraoral scan, and you have a crown. Screw-retained crown. So the hole in there is to give you access to the implant head. And you screw your crown in, and then that's it. That's what you have. The last but one is the immediate placement. You have a tooth there, you take the tooth out. Normally, it's very, very tedious having to put an implant in a gap. That was done, but look at this. The tooth is there, but still, you've been able to plan an implant with the tooth there. The ID bundle is there, marked in red, so you know what's going to happen. When you take the tooth out, you know you're going to have a gap already here. You get your bone graft ready, so you can pack it in. Tooth is out, guide is in, implant is in, bone graft material by its side, because you know from your clone. You stitch up, 3 months later, crown, and that was an implant I did next door to it, 2011. The old way. And you put a filling on top. And you can see I've deliberately made that crown infra-occluding with its opposing one. So you have a gap there. When it comes to the maxillary sinus, dentists really get worried because we don't have enough bone to place the implants. The maxillary sinus migrates downwards as you take the teeth out. So, in this case, the patient has lost the last 3 teeth at the back. Surgical guide has made me position the implants in its correct position. This particular drill is special. It is blunt. So what it does is it keeps drilling here with your measurement, and it lifts up the bone without tearing the membrane. And when the membrane is lifted, then you can use saline in a syringe to lift it up like a balloon, like here. So you can see saline is put in there, and as you put in there, the membrane lifts up, and then you place the implant. That's a demonstration of that lifting up. But sometimes I take an X-ray just to tell me that I'm actually at the floor of the maxillary sinus. And once that is confirmed, I place my implant pushing it up. You can see my implant is in the sinus, but it is under the membrane. And that's a schematic. And you can see the guide will make you place it in equidistant from each other. And that's the soft tissue after 3 months. That's placed there. This lady, you know, her lip is falling in, concerned. She has got only little bone. If you look at the CBCT, only little. You can only get this from CBCT. You can't determine. You can see the incisive foramen there, here. And so you have only a small diameter to place the implant, and digital implantology will do that. If you look, we are just about missing the canal here. You do all this beforehand, and you know you can place the implant. And you put a guide in there, and you place your implant. They design it, it's a bridge. She has an open bite already, and there you go. And you can see the lip that is sunken has been restored. Lastly, full arch. Patient's teeth are very mobile. Very, very mobile. That's the OPG. That's the design. That's the plan. The guide goes in there, placing 4 implants in the upper, placing 4 implants in the lower, and putting a fixed bridge on it. So you can see the holes here. It's where we'll be placing the implant, just immediate. You can see the screws here secure the guide into the roof of the mouth. Please remember that because we've had the design, we've already made the temporal bridge. This is the temporal bridge, already done. So once you place the implant, you put the temporal bridge in there. And you do the same for the lower. And that's the implants put in there. And you can see it's been angulated to maximize where you have bone. Look at this place. That's the maxillary sinus there. But because you planned ahead with CBCT, you're avoiding the maxillary sinus by placing the implant at an angulated position. And that's the temporary prosthesis. Placed at chair side the same day. Treatment started at 9 a.m., finished at 5 p.m. I won't do that again. Yeah, it's really. Final one. And that's not the final one, but remember that case. That's the patient. Okay, the photo I said you should make a mental note of. So you can see the gum has grown around there. A little bit of edematous gum here. And this is just acrylic. Yeah. Lastly, this patient, bad teeth, same situation, all over the place. So we had a chat, and it was just the upper. So we did all the cloning, the planning, made the temporary, everything. Patient came in, we put the guide in, and look at the planning. Okay? That is the guide. 6 implants at the top. And this designed to fit in the roof of the mouth. Secure. And then cut off later. And this is where what happened. It was challenging. We took the teeth out and placed the guide in there. You can see the implants in there. Here, in the sockets. And that fitted on it. I saw the patient 2 weeks later. And that's how she looked. And that is the kit that we can talk about later. We have about 8 implants that you can try outside. Thank you very much. Any questions?
That's been wonderful, Dr. Nana Echampong. I think we can give it out again to Dr. Echampong. These ones, I don't think have been done in a salon. So we need to take the fight out there. I'll allow for 1 or 2 questions for Doc, if there are any. All right, let's have the first one from. Can I be helped with the microphone, please? Doc, please join me up here. There are some questions for you. Please go ahead, introduce yourself, and then.
Hello. Is the mic working?
Yes, please go ahead. That's Edwin, right?
Yes,
Yes, Edwin, go ahead.
Okay, thank you. Edwin Kwame here. So, Doc, thank you so much for enlightening us with your procedures. We've learned so much. And my question is on your slide 97. I wanted to find out the purpose for which you kept the restoration out of occlusion, and also if the patient is masticating, could it not perhaps defeat that purpose?
That's a good question. I did an immediate implant. This is not routine. So this patient, it was an immediate implant. 3 months survival is okay. I know, I'm sure Dr. Eduako will tell me that the top teeth will over-erupt with time to meet it. But I wanted just to buy time with that patient. So I don't do that normally. But when I fitted the implant, I realized favorably that there was a little gap for me. But the digital technician would make it in such a way that there's all balanced occlusion even on your implant. But personally, implants don't have a PDL, periodontal ligament. So I tend to not to load them like a normal tooth. I'm sure Doc will tell me about the research paper.
Any more, please? All right, we have another one here.
Good morning. Please, I'm
morning.
Irene Kato. I want to find out about the blunt drill. Is it a drill that comes with the system that you were describing, or is it a drill that we can access from other implant systems? And then I was curious about the saline that you pushed over for the sinus lift. After pushing the saline, did you place bone grafts? Because I didn't see that in the images.
Good question. So let me take the first one. The first one is about the blunt drill. The blunt drill comes in a kit called the One Cast kit from the Ostem group. Now what it does, instead of the normal implant drill, which is slightly pointed so it can penetrate cortical bone, the blunt drill is not pointed. It's flat with a little bit of concavity inside. And when you use it, it feels like drilling in reverse. So what it does is it drills the bone and carries the bone to break the cortical floor underneath the sinus membrane, so you don't tear it. Okay. The next question is, research has shown that if you have a blood clot there, right, you can leave it and it will get that osteogenic potential to generate bone. Some people put, or many people put bone graft in there. What I don't like is, it's like root canal treatment. Dentistry, sometimes we employ blind procedures. And if I shove the bone graft material too much in there, I may tear the sinus that I'm protecting because I haven't felt it properly. Talking about the saline, once that flat drill breaks the floor safely, you feel a give, and you take a probe, not the normal probe, it's got a flat end, and that will tell you that that's the membrane you are feeling. You fill your saline 3 millimeters in a special tube, and you make sure there's no air bubble right to the tip, and you inject 1 millimeter, in fact 0.5 millimeter, into the sinus or the floor of the sinus, and then draw back the same amount. When you draw back, you see blood, clear blood. That means you haven't perforated. When you draw back and you see bubbles, then you've perforated. Then you abandon ship. Okay. Then you go 2 millimeters, it raises it more. You draw back blood. And then maybe 2.5, it raises more. You draw back blood. And if you're a fan of bone graft, you put the bone graft material in there because you know you haven't torn. And then you put the implant in. Thank you.
Thank you. All right, I can't see any more hands up. So we thank you, Dr. Nana Champon. You are discharged. Our next presentation will be from Mega Life. Please, let's welcome Mega Life for a 10-minute presentation. This year, I'm keeping to my time, 10 minutes. Thank you. Let's give it out to Mega Life, please.
Thank you. Good morning, everyone. Greetings from Mega Life Sciences. If we've already met this year, then Happy New Year. But if we haven't, then Happy New Year now. Please hope we are all doing well. We are looking so ravishing for today's Congress. My name is Renee Afonyako from Mega Life Sciences, and today we want to do a summary presentation of some key brands that will be relevant for the dentistry space. So at Mega, we have a few goals. We say that we care, and what do we care about? We care about your health, we care about your wellness, and this practically drives our passion to develop quality medicines in order to improve the quality of life. So Mega Life Sciences is a pharmaceutical company into manufacturing, distribution, and marketing of pharmaceutical drugs. Today we'll look at a few products which can be used in the management of our dental pain. We'll look at some relevance of vitamin B and C supplementation as well as probiotics for dental practices and some innovative solutions. We are in an era where everyone is hopping on to fast food, to fast internet, to fast cars. So why then wouldn't we look at fast pain relief? It should be a matter of concern in this era. And that is why for the first time in Ghana, we are introducing the Clear Cap technology. One would ask, what is that? So it is a technology which is used in the formulation of our Gofex 400 milligram capsule, which is our brand of ibuprofen on the market. And what this does is that it helps to increase the dissolution phase of ibuprofen. Any standard ibuprofen tablet has a long resilience time when it comes to dissolution. And because dissolution is a practical or an important and essential thing when it comes to pharmacokinetics of drugs, we want to ensure that the drug solubility of any product is optimum or optimal for the patient. And that is why Mega Life Sciences decided to introduce Gofex. and that is our pre-solubilized ibuprofen brand on the market. And this is formulated, like I said from the beginning, using the clear cap technology. And this is going to help eradicate your dental pain. The dose for Gofex is 1 capsule 3 times daily after meals for children 12 years and above and adults. So with Gofex, we are saying that you are ensuring excellent bioavailability, you have rapid absorption, you have a much faster pain relief, and then you have a much lesser GI effect. For today's conversation, we'll be interested in dental pain, but beyond that, all other pain conditions, Gofex is relevant or essential for eradication of your pain. Then we also want to look at the relevance of vitamin C and vitamin B supplementation in our dental practice. When it comes to wound healing, vitamin C plays an essential role. It helps to fasten the healing process. And whenever there's a deficiency of vitamin C, it means that there will be a slowdown of the healing process. And that is why we are introducing to you today our Nat C, which is our brand of vitamin C 1000 milligram on the market. It is much safer and gentle for the stomach. Our Nat C contains some essential ingredients. First, of course, you have the vitamin C 1000 milligram, but aside that, we have our citrus bioflavonoids, which help in better absorption of the vitamin C, giving you a much better bioavailability. Then we have our rutin and our hesperidin, which are potent antioxidants to help reduce oxidative stress. And then also we have rose hip and acerola extracts. And these are natural vitamin C sources. So what they are doing is that they are offering you some form of synergy. They are adding on to the original vitamin C 1000 milligram that is readily available in Nat C. And then also we'll know that for some of the compositions of the vitamin C, we have the salt forms of ascorbate. And what this does is that it helps to offer a much gentle and safer effect for the stomach. So unlike other vitamin C supplements on the market, which are much harsher on the stomach, the salt form of our ascorbate makes Nat C more gentle and safer for the stomach. So some advantages or benefits of Nat C over other ordinary vitamin C. One, it has the high strength because of the incorporation of the citrus bioflavonoids, increasing or enhancing the bioavailability of the vitamin C. Then also we have the addition of the acerola and the rose hip extract, also acting on a synergy to offer you higher antioxidant effect. Then also, we are saying that Nat C has 4 times the potency compared to any ordinary vitamin C on the market. And finally, it is more gentle on the stomach because of the usage of the salt forms of our ascorbate. Then we move on to our vitamin B supplementation in dental practice. Vitamin B deficiency has been shown to predispose patients to some developmental defects, to periodontal diseases, and also some mucosal lining defects. Vitamin B12 deficiency also predisposes patients to mouth ulcers, to mouth sores, to glossitis, and also alterations of taste in patients. So it is always essential that we have some form of vitamin B complexes for our patients, as our foods every day are not able to give us the optimum amount of vitamin B needed by the body. Currently, the market offers 2 of these vitamin B complexes, either a high dose of some selected vitamin B or a low dose of all of the vitamin B complexes. But it is essential to ensure that there is a balance between all number of vitamin B complexes within the formulation. Also, in addition to that, there should be some biotin, some choline, and inositol helping in better recovery of the cells. And that is why we want to introduce Nat B to you today. It is our vitamin B complexes containing optimum doses of all the vitamin B complexes, in addition to folic acid, to biotin, to choline, and inositol. The dose for Nat B is 1 capsule daily. And it is indicated for all your neuropathy cases of multiple origins for your canker cells, and then also for nerve regeneration after your tooth extraction. It's also essential as an adjunct therapy for your trigeminal neuralgia. So that also is a type of chronic nerve pain which often affects the trigeminal nerve and affects impulses moving from the face to the brain. And according to guidelines, we are saying that oftentimes the gamma aminobutyric acid is what is often used as first line for the management of trigeminal neuralgia. And amongst this, you can have your gabapentin, you can have your pregabalin, you can have your topiramate. The American Academy of Neurology and other societies are saying that for first-line therapy for management of trigeminal neuralgia, you should look at using your pregabalin. And that is why Mega Life Sciences decided to introduce Ligaba. And that is our brand of pregabalin on the market. Currently, we have the 75 milligram readily available for your trigeminal neuralgia. And this is going to help reduce the hyperexcitation of your neurons. Finally, we want to look at the relevance of probiotics when it comes again to the dentistry space. The intestinal microbiota is made up of many microbiomes, and they are responsible for several functions, for protective functions, for structural functions, and metabolic functions. But then, whenever there is an imbalance of bad and good bacteria, we call that dysbiosis. When the bad bacteria overrides the good bacteria, there are certain things that happen. First, there can be increase in the gut permeability, there can be increase in septicemia, there can be increase in systemic inflammation, they can even predispose the patients to getting some cardiovascular diseases or even irritable bowel syndrome. So it is always essential to ensure that there is always normalization of the gut flora. This dysbiosis has the ability to cause diarrhea in several ways, but amongst two of this is what we want to discuss today. First, dysbiosis has the ability to cause diarrhea through osmosis. It causes accumulation of disaccharides along the gut lumen, forcing water into the lumen and resulting in osmotic diarrhea. Secondly, it also has the ability to increase mucosal infections and inflammations, drawing water and electrolytes again into the gut lumen and resulting in diarrhea. It is therefore essential to look at stopping diarrhea and normalizing the gut flora. And that is why Mega Life Sciences is introducing NormaGut to you. That's our brand of freeze-dried yeast of Saccharomyces boulardii. It helps to shorten the duration of diarrhea. It also helps to normalize stool frequency and finally helps to restore digestive health. NormaGut is indicated for both your acute and chronic diarrheas. But for today's discussion, we'll be interested in the antibiotic-associated diarrheas. And these often occur from day 2 to 3 during the antibiotic therapy. So we are looking to stop this antibiotic-associated diarrhea which often occurs with our antibiotic therapies. So for children 2 months to 2 years, we are recommending 1 capsule daily. And then for children 2 years to 12 years, we have 1 capsule 1 to 2 times daily. One would ask, how do we give a capsule to a child? So you twist open the capsule shell, you mix the contents with water or juice of the child, and you ensure that the child takes all of that solution at a go. And then also for children 12 years and above and adults, it is 1 capsule twice daily. And the good thing or the unique thing about NormaGut is that you often take the NormaGut in conjunction with the antibiotic during the antibiotic therapy and then 2 to 3 weeks after the antibiotic therapy to help eradicate the antibiotic-associated diarrheas, especially with our amoxicillin-clavulanate combinations. Thank you very much.
Thank you very much, Mega Life. Just stand by me.
Yes, please.
Today, my presenters are doing well. Mega Life just did +1 30 seconds. but it's good. It's good. It's good.
Yes, please.
Any questions for Mega Life, if there are? Any questions? We from the village.
Yes, please.
Our patients are always using national health insurance. are your products on the health insurance that we can easily give to our patients?
Currently, no, but they are very affordable. So yes, they can afford. No, it is not on insurance.
You heard it too. I didn't say it. All right. Okay. Thank you very much,
Thank
Mega
you
Life. We are
too.
grateful. We have our audience online. There's a live streaming of this morning's activities. And so, audience online will be coming to you. If there are any questions, let us know. We'll engage you as we go along. You are part of us. But we encourage that as many of you that can come in person and be here, please do join us. The day is still young, so join us. I want to appreciate on behalf of the National Executive and the entire association, we want to extend a big appreciation to Eagle Eye Project and Events. They have been a good sport. All the beautiful technology that you see here is courtesy Eagle Eye Projects and Events. They are streaming live for us, and they are sponsoring and supporting our activities for the next few days that we are going to be here. I think that is a good time to give it out to Eagle Eye. We are so grateful, and we know you are going to do more for us. Thank you very much. In due course, we appreciate other sponsors and partners. The next presentation, another 10 minutes presentation. I'll see whether they will beat Mega Life. Will be done by Crown Health. Crown Health. Let us welcome the representative for Crown Health with a round of applause, please. We have 10 minutes. Thank you.
Hello, good morning. Firstly, thank you for having me here today. My name is Lee, and I actually work with the Vartec UK, responsible for the Africa as an education and the sales manager. So I was introduced as a part of Crown. Yes, the Crown is our local partner, official partner in Ghana. But if I may briefly introduce about Vartec. Vartec is a dental imaging equipment specialist. We are from Korea, and so the machine, everything is made in Korea by ourselves. And we are currently ranked as a world #1 CBCT and OPG manufacturer. So today, I would like to go through briefly why the CBCT is the only way forward in a modern day dentistry. I'm sure we have a dentist from many different backgrounds, from general dentistry, implant, as well as the endodontic, and all of those clinical fields. I'm sure you are well aware that the CBCT are heavily utilized for clinical workflow. So it's no secret that in modern day dentistry, maybe it's not the CBCT, but the two-dimensional image in form of the panoramic X-ray or the PA or the bi-twin from the intraoral X-ray system is heavily utilized, and it is obviously giving you the more precise clinical data that help you to come up with a better and a more accurate clinical diagnosis, and that will eventually lead you to have a better treatment planning, and again, that will lead you to the happy patient. And these are the level of clinical work you can do. Oh. So you can do with the two-dimensional image, general anatomy, pathology detection, such as caries, bone evaluation at a certain level. So you can come up with the number of different treatment planning, I would say, in terms of general care, endodontics, and the periodontal, and the basic oral surgeries. By the way, the image on the right, that's one of the panoramic X-ray from the Vartec OPG machine, along with the AI-powered pathology software. Well, I'm sure you could notice this photo already. Honorable gentlemen who done the first presentation have shown this image. And rather than me going through all the limitation coming from the 2D, well, basically, the human mouse is a three-dimensional object. And we are trying to acquire clinical data from this 2D image. So it is obviously giving you a lot of limitation in terms of superimposition, magnification, and the distortion. So the possibility of the distortion within the two-dimensional image is actually up to 30%. Whereas with the CBCT, the possibility of the distortion rate is actually less than 2%. So that tells a lot of a difference in terms of clinical data. So for example, if you measure the distance before the surgical extraction from the apical end of the wisdom teeth to the superior border by the nerve, using a CBCT, I can't obviously say 100% in science, but it is 99% accurate when it comes down to the proximity length measurement. But with the 2D, you can't take it as it is because there is an issue and the limitation from two-dimensional image. So one popular journal, same two-dimensional image, I think it was a bite-wing image, was shared among with the 50 dentists. The agreement rate in clinical diagnosis from 50 dentists on the 1 2D image, same image, was actually less than 50%. So the photo you've seen this morning, so you know what's going to be next. So this is the image from the lateral point of view. It's going to make everyone's eyebrows raised. So what's going on there? So that's the PA point of view. That's actually the case where Prince William arrived at the hospital when his wife was giving a birth to his third child. And now he's saying, oh, now I'm a father of 3. So if you can basically have the context of the whole story using a CBCT. So this is how CBCT is acquired. CT, what's the first word you come up with? Radiation, right? But in fact, CBCT is only focusing on one area with a one scan. So basically, the patient is going to be getting far less significant level of the ionizing radiation compared to the multi-slice, the general medical CT. In fact, patient is getting only less than 10% or even 5% of the radiation from CBCT compared to the general medical CT. Of course, there's a little bit of limitation coming from the CBCT in terms of artifact, density. The value itself is not as accurate as the general medical CT, which are presented under the Hounsfield value. But there is always a way to go around that limitation as long as you know how to move the images well and they're using the software very well. So, of course, I'm not going to go through every single pages, but actually, according to the position statement of the American Academy of the Oral and the Maxillofacial Radiology Society, it is now actually recommending dentists to take CBCT on a patient before planning the implant. That's again, the safety aspect of taking a CBCT. Yes, having a CBCT, you are basically giving an ionizing radiation to a patient, which can cause a deterministic effect, such as a cell death, or stochastic effect, which is causing a higher risk of having a cancer in their life. It sounds scary, that self, isn't it? Having a stage, increase the chance of having a cancer. But in fact, it is pretty much nothing. I can't obviously say, it is negligible, but in fact, taking a full mouth OPG is only the 2 days of natural radiation. What is the CBCT? Taking a full mouth CBCT there is only 4 days of natural radiation, maybe 5 days, or 4 hours of the short-haul flight. I was flying from London to Accra the other day. It was a 6 hours flight, so it is equivalent to the 1.5 full mouth of CBCT I was taking as far as the ionizing radiation is concerned. Was I worrying about getting ionizing radiation, having a higher chance of the cancer? No, I was very excited. So maybe this is something you can utilize for your patient if you have a CBCT or even a small X-ray. In fact, did you know that eating 20 bananas, you get the ionizing radiation equivalent to take one between? Yeah, really. You get an ionizing radiation from their food. 25 Brazilian nut, same level of the ionizing radiation, same level of the risk of getting a cancer by taking a small X-ray. So this is the level of the radiation patient will get. Well, this is, of course, as a clinician, even though the level of the radiation the patient is getting is pretty much nothing, but I'm not in a position where I can say, oh, it is negligible, please feel free to take the CBCT all the time. I can't say that. So that justification must be coming from dentist oneself, of course. But for example, even a pregnant patient, the baby, it is getting a radiation when the mother is getting a CBCT, but ionizing radiation is actually less than 1 day. It looks like I'm running out of time, so I will skip through. So what you can do with a CBCT, so you basically can see whole different level of the clinical data. It's not about the better image quality compared to the 2D. It's not about the quality image of the image, but it is about the in-depth clinical data you can acquire from the CBCT image itself. So cracked tooth, early sign of the cracked tooth, you'd never be able to get it from two-dimensional image, but by the time you see the sign from the adjacent anatomical changes, like a widening of the periodontal ligament, J-shaped radiolucency, maybe it's a bit too late. But with the CBCT, if you look at the image on the right, that's the 2D image. Can you see the vertical fracture there? No. But with the CBCT, because we can basically see every single slice of the images, coronally, sagittally, and axially in a 360-degree view, you'd be able to find and see what you cannot see. The lens area in endodontic treatment, again, two-dimensional image. There is a bit of a radiolucency out there at the apical end, but I don't know exactly what's going on. It seems like treatment done okay, but if you look at the CBCT image, it has been underfilled. It has been underfilled. You can see that from axial point of view. If you look at the distal buccal root there, it's been underfilled there. MB2 canal with the Vartec, the system Vartec. Vartec is the only manufacturer offering the CBCT where you can find the MB2 canal because we're using a smallest voxel size in the industry. Implant, risk management, you can precisely track down the ID nerve. Look at this. This is actually my own image. I took this image in Addis Ababa in Ethiopia last year from my, one of my client dental practice. Yes, I know I need an implant. I still haven't done it, so if any of you are doing a good implant, let me know. This is the 2D image. What is the length from the distal root, end of the distal root of the lower right 6 to the superior border of ID nerve from the 2D? It looks like about 8 millimeter there. Okay, but if you look at the real CBCT image, it is only 6.2 millimeter. Imagine this was the case, which the distal root end of the distal root is very close to the superior border of ID nerve before the surgical extraction. This is the case where the CBCT was showing. Unfortunately, the apical end of the implant was placed on the ID nerve, which you cannot see from 2D. Maybe this was done without having a CBCT, but yeah. And this is the beauty of the CBCT for implant dentist here. You can measure everything from occlusal to the superior border of ID nerve. You can measure the cortical plate to cortical plate, and you can measure the length from the apical end of the implant to the superior border of ID nerve. So that gives you the precision and the confidence. So any of you are using a 2D only, I'm sure you know sometimes if this is a difficult case, you might have to refer a patient away. you know, so you have to sometimes cherry pick the patient, but having a CBCT, you can do implant with a full of confidence. You can measure the bone density. It is a key factor to determine the success of the implant. You can measure the bone density of the cortical plate as well as the trabecular bone level as well. You can measure the sinus flow volume, so precisely understand before the sinus lift what is the volume of the grafting material you have to use. You can understand the different anatomical, you know, character, accessory mental foramen here. Before the sinus lift, what is this? It's on the sinus floor. It's a posterior superior alveolar artery. Sometimes it is positioned quite inferiorly, and accidentally, if this was damaged during a sinus lift procedure, well, the result is not ideal to face, I guess. You can also merge the STL file into the CBCT, so you can do the digital guided surgery. Post-implant assessment. And I'm going to show you a very interesting video there, but can you play this video, if you can, please? So this is the Vartec. Oh, okay. So I'll go for another 1 minute if that's all right. So this is an AI-powered software where you can segment up to 135 anatomical elements. I'm not talking about only the bony element, but non-osseous element as well, including the condyle, TMJ, sinus, and even a root canal as well. And this is where you can find the ID nerve using an AI-powered software. And now the AI is helping you to simulate the implant. You don't have to do all that measurement, cortical plate, occlusal to the superior border of ID nerve. Basically, the AI-powered software will simulate the implant. Of course, at the end of the day, it needs a verification from the dentist, but you don't have to spend like 10-15 minutes sitting down on your desk while the patient is waiting for you. So you can run through using an AI within 2 seconds. The implant will be there for you. This is a STL file. I'm sure any of you doing a digital implant, it is quite a bothering process to merge the STL file into a CBCT. But now using an AI-powered software, just all you need to do, click, drag, and a drop, that STL file will be merged into the CBCT straight away. And this is again the highlight of the AI-powered software from Vartec. With the Vartec system, we can track down the root canal. We can track down the root canal, so that means AI will categorize any character, mesial buccal movement of the root canal. So as you can see the video there, you can precisely understand the full anatomical character, including a length, diameter, degree of the curvature. So this is almost like a surgical guide for the endodontist, if we have endodontist here. So you can precisely understand what is the length, and based on the curvature, you can understand how to maybe curve your file, and what kind of technique and the degree of the file should be. And actually, this premium Vartec CBCT has been installed at the Busy Bite Dental Practice in Accra, which is great machine for the endo implant as well as the maxillofacial surgeons as well. We capture the 12x15 whole facial scan as well. So if any of you are interested, send your patient, please feel free. Yeah. And this is Vartec system. I'm actually positioned, once you left the building, just on your left, I'm there with a crown, so I can show you how CBCT can work. And all this workflow, I can tell you, I have a zero clinical background, but I'm very confident of using a software to do everything, like simulating an implant, do the measurement. So once you're familiarized with the software, I'm sure the world is your oyster. Thank you. Sorry that I've gone over.
All right, thank you, Lee.
Any questions?
Even though I know you are not a clinician, I hope you won't do quackery. All right, good. Any questions for Lee? Let me say that Lee has taken some minutes out of our coffee break, so hold him responsible.
Sorry for that.
All right, any questions? I can see that you were all enjoying the presentation. I will get you. All right, any questions for Lee, please? Yes, Doc.
Sorry?
Are you located in Ghana?
No, actually, I'm based in the UK. The VATEC is the headquartered in Korea, and we have 30 overseas branches. So now I'm based in the UK. Now I'm based in the UK, but I'm covering the whole Africa. So once a month, I come to visit the different part of Africa, which I'm very much enjoying. And I will be making a very regular visit once in every quarter. Yeah, to do the training, and I do a lot of webinar for the dental associations as well. Yeah.
Okay. Because I was wondering how we can contact you for further.
I am more than happy to give out my personal contact if you make a visit to the Crown booth, and I can help you to get some consultation. Nothing about commercial, but I can go through more why the CBCT is a way forward in a modern dentistry. Thank you, sir. Sorry that I got that.
All right, let's give it out to Lee. We are fighting quackery, so let's do the right things the right way, right? Great. At this point, we'll take a short break. We'll have they say it's coffee break, but I know there is tea, and there are other things. So we'll take a coffee break. The coffee break is just outside the gate. We are just going to do some 10 minutes outside the door, right in the lobby. Just grab something, wind down a bit, coffee off the traveling stress, and then let's gather again for the main scientific session. So we are taking a 10 minutes break. We will be back here exactly 35 minutes after 10 a.m. Thank you very much.
If you are playing Superjet, take note. They are
Somebody is working out the sound system. The sound system. Say Jaja rhythm. Jaja rhythm. Moving through space and time. Brother don't fear, ain't got no fear. He's beating down the best line. Why don't you get on board the Zion Express? It's saying Coco, Coco, it's Cocadera. Coco, Coco, it's Cocadera Rasta. Rasta yeah. Coco, Coco now, Cocadera. Coco, Coco, it's Cocadera Rasta. Rockin' African rock you. In the night, in the day, we burn rock your soul. Positively moving up, oh, within your time. No matter what you say or do, Japan will rock you down. That's why we saying Coco, Coco, it's Crocodile. Coco, Coco, it's Crocodile Rasta. Coco, Coco now, Crocodile. Coco, Coco, it's Crocodile Rasta. Rockin' African rock you. In the night, in the day, we burn rock your soul. We positively moving up, oh, within your time. No matter what you say or do, jump on the rock and down. That's why we saying Coco, Coco, it's Cocodile. Coco, Coco, it's Crocodile Rasta. Rasta land. Coco, Coco now, Crocodile. Coco, Coco, it's Crocodile Rasta. Coco, Coco now, Crocodile. Coco, Coco, it's Crocodile Rasta. Baruch Ata Adonai. Baruch Abba Yerushalayim. Baruch Ata Adonai. Baruch Abba Yerushalayim. From the Bible to the Quran, Revelation in Jerusalem, Shalom, Salam Alaikum. You can see Christians, Jews, and Muslims living together and praying, Amen. Let's give thanks and praises. Baruch Ata Adonai. Baruch Abba Yerushalayim. Baruch Ata Adonai. Baruch Abba Yerushalayim. Jerusalem, here I am. Jerusalem, je t'aime. Jerusalem, here I am. Jerusalem, je t'aime. Israël Yakirati. Israël Yakirati. Ani Oevota. Israël Yakirati. Israël Yakirati. Israël Yakirati. Israël Yakirati. Ani Oevota. Israël Yakirati. From the Bible to the Quran, Revelation time, Shalom, Salam Alaikum. You can see Christians, Jews, and Muslims living together and praying, Amen. Let's give thanks and praises. Baruch Ata Adonai. Baruch Abba Yerushalayim. Baruch Ata Adonai. Baruch Abba Yerushalayim. Jerusalem, here I am. Jerusalem, je t'aime. Jerusalem, here I am. Jerusalem, je t'aime. ya hakirati. Israel ya kirati. Israel ya kirati. Israel ya kirati. Ani oevota. Israel ya hakirati. Jerusalem, here I am. Jerusalem, je t'aime. Jerusalem, here I am. Jerusalem, je t'aime. chip on the left hand side. Pass the dutchie on the left hand side. It a go bun. Give me the music, make me jump and pump. It a go done. Give me the music, make me jump. It was a cool and lonely, breezy afternoon. How does it feel when you got no food? I could feel it 'cause it was the month of June. How does it feel when you got no food? So I left my gate and went out for a walk. How does it feel when you got no food? As I passed the dreadlocks camp, I heard them say, how does it feel when you got no food? Pass the dutchie on the left hand side. Pass the dutchie on the left hand side. It a go bun. Give me the music, make me jump and prance. It a go done. Give me the music, make me rockin' at the down. Dang bang middling, bang middling, bang 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 middling, bang middling, middling, bang. Hey. So I stopped to find out what was going on. How does it feel when you got no food? 'Cause the spirit of Jah, you know he leads you on. How does it feel when you got no food? There was a ring of jets and the session was there in swing. How does it feel when you got no food? And you could feel the chill as I seen and heard them say. How does it feel when you got no food? Pass the dutchie on the left hand side. Pass the dutchie on the left hand side. It a go bun. Give me the music, make me jump and prance. It a go done. Give me the music, make me rockin' at the down. Me say listen to the drum and me say listen to the bass. Give me little music, make me wind up me waist. Me say listen to the drum and me say listen to the bass. Give me little music, make me wind up me waist. I say pass the dutchie on the left hand side. Pass the dutchie on the left hand side. It a go bun. Give me the music, make me jump and prance. It a go done. Give me the music, make me rockin' at the down. You play it on the radio, and so me say we a go hear it on the stereo. And so me know we a go play it on the disco. And so me say we a go hear it on the stereo. Whoa. Pass the dutchie on the left hand side. Pass the dutchie on the left hand side. It a go bun. Give me the music, make me jump and prance. It a go done. Give me the music, make me rockin' at the down. On the left hand side. 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 We say east, we say west, we say north and side. This is gonna really make me jump and try. We say east, we say west, we say north and side. I'm 16 and I'm a bullet in your hands. He's a bullet, little girl. Keep away from him. I'm 16 and I'm a bullet in your hands. He's a bullet, little girl. Watch out! I'm quicker than a flash. Don't talk no trash. Another time, 2 times 8. I'm strong enough to pull my weight. I'm 16 and I'm a bullet in your hands. He's a bullet, little girl. Keep away from him. I'm 16 and I'm a bullet in your hands. He's a bullet, little girl. Watch out! I can sweep you off your feet. I think I finally met my match. If so, I desire. There's gotta be a catch. I'll blow you away. Your reputation is a mess. With my rapid fire, I need a bulletproof vest. I can shoot you down. Ooh, you take my breath away. With one hot kiss, you know what to say. I've got something you girls just can't resist. What's that, Kelvin? I'm 16, 16, 16, and I'm a bullet in your
We will want to ask all those outside to please come in for us to continue with the activities for the day. So all those at the exhibition, please, for now, the exhibition should close. Everybody should come in, take your seats, and let's have the scientific presentations. Can my deputies help me bring all those outside in? I want everybody seated, because this is one of the reasons why we are here. As for the products and the buyings, we'll do them. Please, all those on the exhibition floor, can you please come in? Those at the snack table, you can bring your snacks in. Bring your snacks in while we continue, please. I can still see so many people loitering outside. Please come in. We are waiting for you. Okay. Let me welcome you back once again. I'm informed that we are having this Congress in Accra. Unfortunately, Madam Chairperson didn't welcome us in Ghana. So, I want to welcome you to Accra in Ghana. I know that many of you have heard how we welcome you in Accra, but I'm sure you have been saying it wrongly. So today I'll bring the Ghana in me to correct all of us. So the greeting to welcome you in Ghana is Obake. Those of you have been saying Obake and Obake. No, it's Obake. So you are welcome. In Ghana we say Obake to our 35th Annual General Congress. Or if I say Obake, what do you want to Madam President asked me, how do you respond? You say you mean Dabushi. If I go to my place, where's Olo? And you say you, so it's the same thing. So you are all welcome once again. We want to begin the scientific session properly. We are going to have 3 sessions today. 3 sessions. And so for the first session, the moderator is a fellow of the Ghana College of Physicians and Surgeons. He is an oral and maxillofacial surgeon. He's been in practice since 2008. He has worked at various hospitals in Accra and in the Eastern region. He's passionate about dentistry and its future. Currently, he works at the Greater Accra Regional Hospital. And he lives in Accra with his lovely family. He enjoys football. And until recently, he has been a long-suffering Arsenal Football Club supporter. But today we are happy that his sufferings have ended. Please help me welcome to moderate the first session of our scientific meeting, Dr. Sylvester Owusu as the moderator. Sylvester, down so. Yes.
Thank you very much for those kind words. Indeed, we have been long suffering, but every dog has its day. So, distinguished colleagues, ladies and gentlemen, it is with great pride and honor that I accept the privilege of chairing this important scientific conference of the 35th General Annual Dental Congress held under the theme Ending Dental Quackery, Restoring Trust in Dental Care. I do not believe I am being overly dramatic when I say that the very future of our noble profession is at stake if we, as dental professionals, fail to confront this challenge decisively. Dental quackery poses a significant threat not only to patient care and public health, but also to the trust and confidence that form the foundation of the relationship between dental practitioners and the communities we serve. The fight against this emerging multi-headed menace cannot be won by any one single individual, profession, or institution. It demands coordinated action and sustained collaboration among dental professionals, regulatory bodies, policymakers, law enforcement agencies, educational institutions, the media, and indeed the public at large. Our duty this morning is not to merely discuss the problem, but to stimulate meaningful dialogue, generate practical solutions, and inspire the collective action required to address it. Through the presentations, discussions, and exchange of ideas that will follow, I am confident that we can contribute meaningfully to the ongoing effort to safeguard our profession and restore public trust in dental care. Thank you all for your presence and participation, and I look forward to a stimulating and productive session. Thank you. So let's kickstart our session. This session, we're going to talk about regulation and enforcement, protecting legitimate dental practice, closing legal gaps, strengthening regulation, and improving enforcement against quackery. We have some fantastic people here to help us go through this. And I have the singular honor of introducing our first speaker, Dr. Alex Piasakodia, who incidentally is my classmate from medical school, is a physician, a healthcare leader, bioethics scholar with over 18 years of clinical experience and more than 15 years in healthcare leadership and management. He currently serves as Deputy Registrar of the Medical and Dental Council of Ghana, where he contributes to strengthening professional standards, patient safety, and healthcare regulation. Prior to this role, he served as Medical Director of Hope Christian Hospital, a CHAC facility at the Village of Hope in Gomoa Fete, where he's led the transformation of a small community clinic into a thriving hospital, offering a broad range of specialist and general healthcare services. Under his leadership, the hospital grew from 6 beds to 85 beds and established one of the few neonatal intensive care units in the country, significantly improving access to advanced neonatal care in its catchment area. Dr. Piasakodia holds degrees in medicine, public health, clinical leadership and management, and practical ethics. He earned a Master's of Public Health from Walden University, USA, a Master of Science in Clinical Leadership and Management from the University of Ghana, and completed a Master of Studies in Practical Ethics at the University of Oxford in the UK. As you can see, Dr. Piasakodia is more than capable of leading this. And so, with a warm round of applause, please welcome my classmates, Dr. Alex Piasakodia.
Thank you very much, Sly, for the wonderful introduction. And thank you, everyone, for the opportunity to be here. I must say that the Registrar of the Medical and Dental Council was supposed to be here. Fortunately or unfortunately, he had to be out of the country for another conference. And so he asked me to step in, albeit late. I had to come. And so, on behalf of the council, I want to extend our warmest congratulations to the Ghana Dental Association on your 35th annual Congress. And we know that this actually is a testament that you are committed to excellence, professionalism, and the advancement of dental practice in the country. And so we want to wish you well in your deliberations and hope to continue with the wonderful partnership that we've had over the years and work together, you know, to clamp this menace of quackery down. So thank you so much for the opportunity. The presentation, please, if I may. I mean, when I saw the topic, and Medical and Dental Council was invited to talk, I knew, well, where it was going. I'm sure people are thinking in their minds, for a long time we've had this problem, what have you been doing? Why can't you solve this problem once and for all? And so then it means we have to come and then have deliberations on how to make sure that we clamp this down. Next slide, please. Or do I have the... Okay. All right. So at the end of the presentation, I want us to understand what regulation and enforcement means, and then also understand the legal framework within which we must operate, and then also understand the enforcement bottlenecks, and then, proffer some solutions to that, and then also know the stakeholder responsibility as far as dealing with this problem is concerned, and then of course we discuss future directions together. So what is regulation? This is a very long definition, but basically what it is saying is that it is a system. It's a framework of systems, laws, processes, institutions that come together to ensure that only qualified people practice medicine or dentistry in the jurisdiction. And I must say that all regulatory authorities in the world, and then of course WHO and all that. So this is more or less a composite definition that I put together. And you can see that it is not the work of just an agency, Medical and Dental Council. Okay, we all have a part to play. And I like this definition. It puts it, in a better way. That it is a public, protection function. Okay, that we all are involved. Okay, so it talks about professional bodies like the Dental Association, employers, Ghana Health Service, CHAG, and all the private, employers, practitioners, we ourselves, because it is our profession, and we must, as a matter of necessity, protect it at all costs. And then, of course, it is a public responsibility. All of us, the patients, the general public, also have a responsibility to play to establish, monitor, and then enforce the standards that we have all come together to set as far as the practice of dentistry is concerned. Of course, and this is to safeguard the welfare of the patient. And so regulation encompasses all these things. So we talk about setting standards, educational standards for the curriculum development and the delivery and all that, and of course accreditation of training institutions, and then accreditation of where they do their housemanship and all that, and then registration and licensing of the practitioners who come out of these institutions, and then credential verification for those who are in the country, those who have trained outside and come, and all that. That is what regulation encompasses, okay? But most importantly, even though it seems to be the last bullet, is the collaboration that we must have with all stakeholders. We can't take it out. One person cannot do it all. In account, we say that Obakufo inside Timi Nkata Nyankoponi. In other words, the council alone cannot do it. Okay, God's eye is so big that not one single hand can cover the eye of God. Okay, so it means we need to collaborate, we need to come together. All right, and then enforcement, on the other hand, is the application of legal and regulatory powers to secure compliance. So we have set the standards, the professional standards, educational standards, accreditation standards, requirements, but then enforcement comes in to secure compliance, okay? And it is such that you do a lot of work there. You subject these regulatory requirements to how people actually follow them. Okay, so it calls for investigations, detection of cases, and all that. And it is all to protect the public. And we must remember the Medical and Dental Council is a public interest agency of the ministry, and that is what we do. And so sometimes people say that you protect the public and then you punish the practitioners, but that is not the case. We are all potential patients and we need to protect ourselves. So the purpose of enforcement is to protect patients and to secure compliance, like I said, and then deter unlawful practice, and then promote accountability. Okay, as professionals, we need to be accountable, and then also preserve public confidence in the profession. So if you have a lot of quacks in the system and they are killing people, and the public, doesn't seem to know, differentiate between who a quack and the real professional is, then they just, put all of us together. And that really creates a problem for our profession. Then people will not want to come to our clinics because they think we will kill them in one way or the other. So within the Medical and Dental Council mandate, how we enforce these standards are through registration requirements, licensing requirements, and then of course the scope of practice. We expect that depending on the level of training, you practice accordingly. You don't do what you can't do. That in itself amounts to some form of quackery, because you are not qualified to do what you are trying to do. And then professional ethics and standards, continued professional development, and of course fitness to practice. And this is an area I want to hammer so well. We've had a lot of practitioners appearing before the Medical and Dental Council for one or two reasons, and most of the time we have realized that there is some underlying fitness to practice issues. And for us, when we say fitness to practice, we look at infirmities of the body and mind that impair practice. And this is something that is coming up a lot. I mean, a lot of practitioners are using drugs, for instance, pethidine and the like, and that is really causing a lot of problems. So we handle all these as well. Enforcement is not only about punishment, and I think when we mention enforcement, that is what, that's the first thing that comes to mind. Oh, why is Medical and Dental Council not punishing these people? Why are they not going to prison? Why are they not arresting them? And things like that. But the real purpose is to prevent harm in the first place. And so public education, professional guidance, and then advisory notices are some of the things that you do as far as enforcement is concerned. And then detection. So you go for inspections, intelligence gathering, complaints handling, and then you do audits of cases that have gone bad. We have had to do what we call head count. So we just unannounced visits, conduct unannounced visits to facilities, and then find out who the practitioners are, whether they are registered and they are on our register, and things like that. Then investigations, fact-finding, evidence collection, interviews, and then, of course, verification of credentials. Then there is the corrective aspect of it, okay? And that is where we will give warnings and then also take disciplinary action against practitioners, and then, of course, issue some improvement notices for practitioners to learn from, and then conditions on practice. Sometimes we restrict your license because of some impairment you may have, or some misconduct you have found yourself in, and then sometimes we will suspend your license altogether. And then we are able or empowered to also close facilities that are being run by quacks. And so a few times we have gone under investigations and found quacks practicing. Of course, we have to collaborate with the police and then close the facilities until the right thing is done. And then, of course, revocation of licenses are there. But I'm sure Hefra will be here to also talk about the facility licensure. The law that governs medicine and dentistry in Ghana is the Part 2 of the Health Professions Regulatory Bodies Act. And it is very clear as far as quackery is concerned. I mean, there are no two ways about it. That a person commits an offense if that person willfully and falsely uses any name, title, or addition implying a qualification to practice medicine or dentistry. So it's clear. Employs or, I think it should be or engages a non-registered practitioner. And this is so common. We have done undercover investigations in various hospitals, and we have found unqualified, unregistered practitioners, quacks, in those facilities. And these are people who have been hired, employed by our own colleagues. And so we go and muddy the waters, upstream. And then when we come downstream, we say, why is this water muddy? We employ them in our various facilities. In fact, you can go to some of the private hospitals now, and I can bet that up to 50% of the practitioners there are not qualified to be there. But you see, we want cheap labor. And so we contribute to the problem. And then we empower them to do things in our absence. And then when we sack them, they go and open shops because they know how to take out tooth. So we need to be careful. If we engage them, then we are contributing to that. And of course, anybody who receives money for such practices is also considered liable to the law. So in simple terms, you cannot call yourself a dentist or a doctor without registration, or hold yourself out as a dentist, practice dentistry without registration. So this is very important. That is the law. The object of the council, like I said, is to secure in the highest, is to secure in the public interest the highest standards in the training and practice of medicine and dentistry. That is our mandate. But we cannot do it all. Okay? So to fulfill that, we do all the things that I have mentioned previously. What is dental quackery? You know it because we have discussed this several times. And I know my boss had some presentation on this some few months ago. Okay, so it occurs when a person practices dentistry without registration, uses protected professional titles unlawfully, performs dental procedures without appropriate qualifications, operates outside approved scope of practice. So there is some sort of internal quackery among us as well. Maybe because we are not qualified to do certain things, but because of money, we go ahead and do that. So, and of course, all these are examples. They are innumerable. You can not count. The cost of dental quackery, you know it better than I do, because sometimes they end up, on your chair. Okay? Infections, facial deformities, loss of teeth, delayed diagnosis, permanent disabilities, death. And we have, done some operations where we arrested about 9 quacks who were practicing for over 12 years around Aguna Swedro area. And it's, you can imagine the harm they have caused to people. Okay? Impact on profession, of course, then reputational damage to dentistry, and then erosion of trust of the public in our profession, reduced confidence in legitimate practice. So those of us who are legitimate and have registered and are practicing, people will project what they have suffered in the hands of the quacks onto us, and then begin to call us names or not even patronize our services. And then, of course, there is unfair competition. The person is not qualified, the person is not having any CPDs, there are no requirements binding them, they just operate. End up, harming people. So that is very unfair. And then impact on the health system, of course, there's increased treatment costs, then litigations, and then reduced confidence in the healthcare institution in general. Why does quackery persist? Because this is a question. We've been talking about it for a long time. Why does it still exist? I must say that, it is difficult to wipe it off. Because even in the advanced countries, there are some people who may find themselves, there are some quacks who may do one or two things. Of course, their system is better, and so the deterrence is there. The demand factors, costs. So people may feel that, well, it's expensive to go to the correct place. And so if there's a wayside, shop that I can, clean my teeth or something, well, I better go there. So they go there. Then convenience. Why do I have to, travel to this place, that place, to get this? There's this person here close by me, or, well, you don't have to be in a long queue, some bureaucratic procedures, and so I'll go there and then have it done. Lack of awareness. Some people simply don't know the difference between quacks and then the legitimate ones. And of course, supply factors, access gaps, like I've mentioned. And we know that dental services are lacking in the peripheries, in the districts. Okay? And so people take advantage, and then go there. Now, there's social media, people just advertise and then make arrangements, meet people, and then just extract teeth illegally. And then workforce maldistribution. We know this. I think Dr. Goka was here. I think we met at a meeting on the National Oral Health Strategy, and she mentioned how in their work they went to some districts and you may have a dental chair, there is no dentist, and things like that. Everybody is concentrated in Accra, Kumasi, because that's where the market is. Okay, so definitely people must fill in the gap. Okay, and so the supply factor is there. And then system factors. Of course, limited resources. If you take the regulator, for instance, it is the whole unit of the complaints and investigations department of Medical and Dental Council has just 2 staff. There used to be 3. One had to go. Just 2. You can imagine. So when they have to do investigations, then they have to fall on other people. It is difficult to handle all these things. Okay? And then there are internal, issues they have to handle. So it is really a big issue as far as resources, human and then capital are concerned. And then weak reporting culture. We don't want to report. We've seen that this thing is bad. But, okay, Miss Ro, I can't do this. Oh, the person must also eat and things like that. And so we don't want to report. It's one thing that, in fact, medical and dental practitioners, I don't know, we find it so difficult. You see that this person has a problem with the mind and needs help, but you won't say it. I won't say it. And the person is causing harm. And you see it, you talk about it, we gossip about it, but we are not able to report for the person to get the necessary help. And then, of course, slow prosecutions. In fact, tomorrow, I'm going to Kumasi. There is a quack PA that we arrested handed him to the police. And once we hand them to the police, it is the duty of the police to prosecute them. But you see, like Prof. York will say, Ghana is like a big compound house. Everybody knows everybody. And so you arrest this person, and then you know, cause. Then the police, you know, they are handicapped. They don't know what to do. And then we are impressing upon them to take action, and it's like, hey, my boss, commander says, and all kind of things. So tomorrow I'm going to meet whoever the commander is and ask why they are delaying. You see, and once you don't do that, then it emboldens them to do what? More. And then other people, oh, this one, if you do the arrest, somebody can just talk on your behalf, and then you'll be, so it continues. Okay, that is the issue. The challenges of enforcement. Detection. Quacks often operate from homes, beauty salons, market centers, and then temporary structures. So it is difficult to locate them. And until somebody reports them to you, you cannot. You cannot. We were in Central Accra. Now we have relocated to Pantan. Imagine. How can you be at Pantan and see things happening at, you know, mentioned in anywhere? It is difficult. So until people report such cases, it is difficult for the regulator to do anything. Okay? Then investigations, limited evidence. Sometimes we report, we don't have the evidence, you know, to pin the people down. And remember, this is all framed in the law. And so before you can put anybody before the law, you must have evidence. And so if you don't have, then you go and then the judge says, well, there's no evidence. Meanwhile, the person has killed people. So we need to gather all these evidences when we want to make a case. And the reluctance of victims to testify. That they are afraid or they are having sympathy or things like that. And then identity concealment. People hide under names. So for instance, there's one PA, again in Kumasi, who has written our licentiate exams, has failed on 2 occasions, and is practicing under, you know, a different name. That is criminal. So if we fish out this person and report to the police, we expect that the police will take action. Unfortunately, no. And then they release the person gets the audacity to go back to the consulting room to see patients. It's just frustrating. Okay, delays, like I have said, and then lengthy trials, weak deterrent effect. There's somebody who has, you know, been caught several times. They go, the courts release them, go and pay, you know, 1,000 Ghana cedis, and they release the person. Then the person goes to do it again, and then pay 2,000. You can't even understand. Okay? Then there is us, the overlooked gatekeepers. We are the gatekeepers. Okay? They are enablers of quackery. Okay? So many unregistered practitioners, like I said, are employed in our facilities. Okay? Or they are allowed to use some facility premises and things like that. And then we present them to patients as qualified. Meanwhile, they are not. We do it. We know it. And every facility has a responsibility to what? To verify the registration status of all practitioners in their facilities. It is the law. Okay? And then we must make sure they have what? Renew their license every year. And then they are practicing within their scope of practice. That is key. Don't let them do things they are not qualified to do. Okay? And then, of course, they are in good standing with the council. So I think that it is all of us together. We are in it together. It is not just the Medical and Dental Council. And so I say that effective regulation is equal to the standards, compliance, vigilance, enforcement, and then public participation. We are all involved. Okay? And if any one of these components is missing, then there's trouble. Okay? Then quacks will enter the system. There's unsafe practice that goes on, and then public confidence obviously eventually will be eroded, and then patients will get harmed. And so these are key responsibilities for all stakeholders. And I'm sure hitherto you thought, well, it is the work of the Medical and Dental Council. They have to do all that. But trust me, it is not true. Okay? So for each stakeholder, there is a responsibility. For us, we have to set the standard and make sure that only those who are qualified enter the practice. In fact, the training and then the practice. And that is why we will go to the institutions, accredited institutions, do inspections and make sure that everything is in order. And then we, the dental practitioners, we own the practice. It is our profession. We have to guard it with all that we can. Okay, so we need to protect it. So we have a responsibility there. And we must, on our part, maintain registration with the council. Because if you are not registered and you are practicing, and another person is also not registered and they are practicing, both are quacks. Even though you might have had some formal training. Then, of course, employers, facility owners, like I have indicated earlier, and then Ghana Dental Association, we must be up and doing. Guard against quackery. I'm not saying that it is your sole responsibility, but go out there, bring those in the communities who are doing things that are putting the name of the profession in disrepute out, and let us deal with them. Then, of course, the Ministry of Health, developing policies. We have had to draft amendments in our law to be presented to Parliament to change so that we can have a lot of some of these things in there. Unfortunately, it has been there. It's been about 7 years at the ministry. Nobody wants to forward it to the Parliament. You can't understand. Okay, so these are all bottlenecks that are there. And then the Ghana Police Service, they have been in partnership a few more times that we have gone under investigation. And then, of course, the Attorney General and the judiciary. Then the media. I think we need to engage the media more so they can offer more education to the public and know who a quack is and who a legitimate practitioner is. And then empower the public to report such cases. All right, so we can strengthen enforcement and deterrence by strengthening detection. So we need to gather intelligence from the community and then also have a reporting system so we can trace all these people, and then also encourage faster investigations and then better interagency collaborations. There are a few times we have written to, for instance, HEFRA, whether we want to know whether this facility is actually licensed by you for any practitioner at all, whether they are in good standing with us or not, to practice there. And it becomes a difficult situation. Sometimes you have people leaking information. Hey. There was one instance where we arrested somebody, and somebody from HEFRA called me. This one, can we do something about it? So there's a problem there. Then timely prosecution, we've mentioned all that. So in conclusion, what I want to say is that the Act 857 provides a strong legal framework for practice. Anyone who practices outside this legal framework is a quack. The challenge is implementation. And the Medical and Dental Council, like I said, is just a single agency. We need collaborations, and we need all of us to be responsible collectively. And then we say that the fight against dental quackery is not simply about removing the imposters. It is also about protecting patients, preserving the professional integrity, and maintaining society's trust in the profession. So effective public protection is about us, the regulators, you, the professionals, the employers who employ you to work in their facilities, and then, of course, the law enforcement agencies, and then the judiciary. Until we come together to fight this and not think that it is the responsibility of one person or one institution, it becomes difficult to deal with dental quackery. So I will encourage all of us to come together. We are there. Our doors are open. And we encourage you to report such cases to what? It may not be immediate, but we will definitely handle it because, of course, I have mentioned we have human resource challenges. But once it comes to us, eventually we go into it. So thank you very much for the opportunity, and I wish you well in your future deliberations. Thank you.
Thank you, Dr. Piasakudia. As you kept talking, I kept sinking further and further in my chair that if we thought the problem was big, it's even bigger than it looks, which also means that the fight is bigger and we need to get our loins and be ready for this fight. Our next speaker is here to help us handle the enforcement bit of this gigantic fight. She's a psychiatrist by training and is currently the head of licensing at HEFRA. Please help me welcome Dr. Alberta Insia Asamoah Mafu. Doc, one of the first things you will ask you to answer is Dr. Piasakudia's, can I say allegation? Yes. So, Doc, please, you have 20 minutes, and then after that, please keep your questions. We will give you opportunity to ask them all. Thank you.
Good morning. I'm here on behalf, I'll be doing this presentation on behalf of our registrar who had to be out of town. As I was sitting in, I was very happy. Initially the program was that HEFRA will present before MDC. But when I came in and MDC was presenting, I was very happy because I thought that he had done half of the work for us, because since we are all regulators, there's a lot of overlap. And then at the end, he threw HEFRA under the bus. I was thinking to myself, do we need to do more collaboration with MDC? Anyway, that's just by the way. When I heard your theme for this year, it got me thinking, ending dental quackery. And I thought to myself, can quackery in any space, end? Can anybody really truly end quackery in any space? For us at HEFRA, maybe we can attempt to do that by combating quackery. And in the end, if we are able to end quackery, then we'll sing praises. Thank you. This will be my outline. For HEFRA, some of you know us, but a lot more people don't know us. I'm saying this because currently, if we look at the number of licensed dental facilities, then you know that a lot of you are not under regulation. Because if you drive through Accra, at every few meters, you see 1 or 2 dental facilities. And yet, when we check our records, we don't have all these people under our records. And so, although we have been to your AGSM, I think a few times, it seems as if the message has not really gone down to your membership. And so each time, we have to keep on introducing ourselves. HEFRA stands for the Health Facilities Regulatory Agency, and we are mandated by law Act 829 to regulate all health facilities. So any facility that says that it's providing some sort of health care needs to come under regulation and needs to come to HEFRA. The difference between HEFRA and MDC is that MDC regulates the personnel, and then HEFRA looks at the facility in its entirety, the services that are being offered there, equipment, etc. We look at personnel, but we do not regulate personnel. So we rely on data from MDC to check these things. And so if MDC's data is not accurate, then HEFRA will not be able to do a very fantastic job. So why does regulation matter? I mean, sometimes when our team goes on enforcement and compliance, people wonder. Some people feel like regulation is an association, like your association is voluntary. If I like, I can join. If I like, I will not join, isn't it? But regulation is not like that. Regulation is mandatory, and it is, mandated by law that everybody should be under, every facility should be under regulation, and that drives standards. So if we are looking to end quackery, it means that then everybody should come under regulation so that standards can be enforced, and those who are not up to standard can either be helped to come up or be weeded out. So I've already mentioned our mandate is to regulate both public and private facilities. Initially, when the law was, the first law looking at regulation of facilities, the law concentrated only on private facilities and maternity homes. But since the new one in 2011 was enacted, now we have equal power or equal regulatory power over both public and private facilities. So hitherto, public facilities thought that they did not need to follow standards. And we have all worked in public facilities before, and we know that a lot of times their standards leave a lot to be desired. So in HEFRA, we stand for excellence. We are getting there. By all means, there may be some bad nuts, but the idea is that we are working towards excellence, integrity as well, commitment. We are people focused. We are driving professionalism, innovation. One of our biggest, outlooks for this year in terms of innovation is to do a lot of collaboration in terms of IT, to do API and interoperability, because when Dr. Kodia was talking, he said that sometimes they write to HEFRA and it takes a long while. And we all know that when it comes to paper things, there are a lot of things. It has to come to the reception. The receptionist has to stamp it. She may keep it for 5 or 10 days before she decides to take it up to the registrar's secretariat. She may also decide to keep it for a few days or even lose it completely. So by the time that the registrar gets it, it's been a month. Then, due to his engagement, by the time he minutes on it, another month before it gets to whichever office that is supposed to respond. Then the office responds, it goes back for a signature, you give it to the driver. The last time I gave a response to MDC to the driver, he said he had no fuel. So that means that he said MDC has moved from Accra to Pantan, he doesn't have fuel. And that's, as you can imagine, it's going to take like 3 months thereabouts if MDC gets it. And of course, we've sent a number of letters to MDC, and then they write back to us and say that they haven't received it. So they also have their challenges at their front desk as well. So because of that, we want to, innovate. We've met a few partners. We've been to the Register of Companies and a few other partners. And MDC is one of our key collaborators. So if we are able to do this interoperability, the minute they sanction somebody or somebody has a disciplinary issue, we can see. It doesn't mean that automatically we are going to withdraw license, but then we are alert so that whenever there's an outcome, we can act on it. But currently, it takes so long. And what we rely on is the MDC Gazette. And we know that if you do late registration, your name will not appear in the Gazette. So there are a whole lot of challenges that we hope that when we drive innovation, we can be able to solve it. So as I've said, the current law that we work with is the 2011. And just like MDC, we have also realized that I mean, as the years go by, your laws needs to be amended. A whole lot of things come up that you didn't consider initially. So that is also a proposal that we have. So what do? We receive applications, and then if your applications go through, there are some mandatory documents. The law mandates them. And our biggest challenge, I know that when it gets to question and answers, people will say that HEFRA takes too long. You apply to HEFRA and your license takes forever. But if your license is going to come early, the first step is you, because the entire registration process is done by you online. And it's only when you've uploaded all your mandatory documents that HEFRA acts. So if you're going to take 1 year to put all your documents together, then HEFRA is also going to take 1 year to come and see you. I hope you understand. That is the first step. Update, I mean, create a profile, put all your mandatory documents on so that HEFRA can proceed with the inspection, and then finally the licensing. Licensing is not automatic. The fact that you are willing to come under regulation doesn't mean that automatically you'll be approved. If you are not up to the standard, because licensing is looking at the minimum standard, which cuts across. If you are not up to the standard, then you'll be denied. Fortunately, we have improved. Now, if you are denied, we write to you. We give you the reasons why we denied you. And then we add recommendations to it so that you know where your shortfalls are. And then we give you time to put in all these things and come back to us and reapply. After you have obtained your license, then we do monitoring. Monitoring is supposed to be done once a year. Every facility is supposed to be visited once a year. But we have the same challenge that MDC has: personnel, logistics, money. These are all challenges that we have. So we are not able to monitor as frequently as we are supposed to. Another one is compliance and enforcement. As we are speaking, the enforcement team is in Kumasi. They started from Western Region, and they are currently in Kumasi. But because of all these challenges, I mean, these are not things that teams have to move from Accra and be going to regions per region. If you have all your regional offices, they should be moving about for monitoring and compliance and enforcement all the time. So those are challenges that we have. And then currently, this year, we are also going to inaugurate our accreditation. License drives standards, and accreditation drives quality. So all dental clinics will not be equal. So why should you all have the same license, or why should you all have the same status? And that has been a question that HEFRA has been asked over and over and over and over again. So we answered it with our accreditation program, so that you can all be licensed as dental facilities, but somebody will be 5-star and you will be 1-star. And that will drive customers, it will drive your revenue, and it will drive a whole lot of things for you. I can see you're all happy with this. We hope that we can convince NHIA to pay the 5-star people more, but that is another conversation. In your subtopic, I think that I saw trust somewhere. And the whole point of regulation is to improve public trust, because public trust depends on safety standards, etc. If somebody comes to you and you did a good job, then they trust in your service. They, broadcast it to other people, and your business thrives. Yes. We have a lot of collaborators. We cannot work alone. As I said, we depend on MDC's data because we don't regulate personnel. We depend on allied health. We depend on Nursing and Midwifery Council. Another thing also is that sometimes people will think that HEFRA, why is HEFRA not doing this? Why are these people practicing beyond their scope? But HEFRA does not determine the professional scope of anybody. If it's a physician assistant or it's a medical doctor, MDC does that. So MDC has to furnish HEFRA with the scope of practice for every practitioner. And that is what we will feed into our inspection tool, so that when we go, we'll see whether you are going out or you are within the scope determined by MDC. It's the same way with all our many partners that we work with. Our facilities are so many. Another challenge that we've had to grapple with is the dental technology labs coming up. We've had a few. Unfortunately, we have been quite slow in catching up, in innovating. So we have all these new facilities coming up, and we don't have the appropriate tool to go and inspect them. And those are things that this year we are working really hard on. One particular area is the aesthetics clinic, because as you know, a lot of the whitening, sometimes even fixing of braces, I don't know if it's cosmetic, but some of these salons do all these things. And initially, Heifer had a problem because we did not have a tool specific for aesthetics clinic. But this year, we've had a whole, stakeholder engagement with them. We've developed a tool, and the tool is ready. We are waiting for our last stakeholder engagement so that we can enforce that. And then when that is there, then we can go into med spas and aesthetics clinics and things like that and ensure that the right thing is done. I think we've gone through this. I will quickly talk about the mandatory documents. These documents are mandatory by law, so there's no argument on it, and there's no explanation around it. You should give us a waste disposal plan. If you're a private, the application process, which is purely online and solely dependent on you. So you really are the rate determining step in our operations. So currently, as of this very morning, I cross-checked again. There are only 117 dental facilities that are licensed with HEFRA and in good standing. And we have an additional 6 that are waiting for signatures, which I am sure your association has a higher number than we do. So it means that majority of your people are not under regulation, and we need to work together to bring everybody under regulation. As of today, again, we have sanctioned 7 dental facilities. I mean, there are more dental facilities, but due to who needs to be sanctioned, really, but due to logistics problems, these are the 7 that we've managed so far. I'm sure that by the time that they come from Western region and Ashanti region, the number would have gone up. And these facilities were sanctioned for a number of reasons. Expired license, not under regulation and all that. Your markets, generally, from where we stand, is concentrated in Greater Accra, backed by Ashanti region. For the other regions, you are not a lot. I think this has been covered by MDC, so I will not bore us all with what Quackery is again. Again, no regulatory oversight. This is purely in the domain of HEFRA. Despite all our challenges, it is still our problem that we need to, And then there's no accountability. Without registration, if you are not under regulation, it's almost as if you are not bound by the rules of the regulator. So you can practice outside what the rules of the regulator speculates and do anything at all that you want. And that is what we've seen with a lot of impunity. If you check Instagram, if you check TikTok, people are doing all sorts of things and advertising, and they have their audience, they have their clientele. And infrastructure or lack of dental clinics and centers is also another thing. If you look at the concentration of facilities, it's concentrated in Greater Accra mainly. So what happens to all those who are in other regions who need to access dental services? So there's a vacuum. Once there's a vacuum, then you are going to get innovative people filling up that vacuum, because people have the need. Somebody must satisfy that need, and that is where Quackery comes in. And so maybe if your association can encourage spread so that other regions can have access to proper dental care, and that will limit the space for Quackery to thrive. So these are some of the violations that we have: failure to renew expired licenses, practicing without formal dental practice. Our biggest problems with the dental centers, especially manned by PAs, is they practicing outside their scope. So we have a lot of that. Oftentimes, they are in very, very remote areas, and then you are faced with a challenge. You are not even able to go there as often as you want. So you can issue and decree and huff and puff, but you are not able to go there as quickly as you want to monitor and make sure that the people remain within their scope. And because there's no other facility within the area, the indigents are going to encourage them. The next clinic is so far away. This one, haven't you seen some before? Why don't you do it for me? You do it for me. And so they encourage them, and they go beyond their scope. Another offense is not submitting service data to MOH, because MOH needs this data for planning, for policy, and things like that. But a lot of facilities do not, and it's actually in our law that is mandatory that you submit your data, your health data, to the DIMS. I think MDC has already talked about where Quackery thrives, in markets, in homes, etc., which makes it very difficult for compliance and enforcement until somebody comes to report. And that has been, reportage has been like one of our biggest source of information. People actually report to us, and then the compliance team sets off. Because as you can imagine, we don't even have the vehicle and the logistics. So the team cannot wake up in the morning and be moving from one market center to another and looking through and standing at corners to see if they can hear something which sounds like a dental, procedure going on and things like that. It's not practical. So reportage is our best bet. MDC also mentioned disguised clinics, which is also another thing that HEFRA is really grappling with. Some of you practitioners will use your license because of the money involved to license a facility in Tamale. Meanwhile, you are working in Accra, you live in Accra for over 5 years, you've never been to Tamale. And we had an issue like that a few months ago. The practitioner works at 37, and yet his license is in Tamale. So who is offering service in Tamale? Of course, an unqualified person. And then we have some people who try to be quite smart. They say we are offering outreaches. We are doing mobile services. So they move from one town to another, and trying to get them is really hard because you don't have their itinerary. You don't know if they move from here, they will get here. Each time you hear of them, they would have just left. And it gets really tough to apprehend them. We've already talked about underserved communities. People are in underserved communities with real dental challenges, and access to proper practitioner, proper dentists is not available. So if somebody brings their mobile outreach dental service, of course, it's also be cheaper. Dental clinics, dental services are so expensive. And so they are going to go to these people to solve their problems for them. I think we all know this as practitioners. We know the risk of quackery. That's why your theme says you want to end quackery. So we will not go too much into this. But the other thing too is that when quackery goes on unabated, you feel the brunt of it, because all the problems that will occur is going to put your name into disrepute, because the public doesn't know who a dentist is and who a quack is. They don't know the difference between a doctor and a PA and a nurse. If you're a female, you are a nurse. So they don't even know the difference between all these people. And people with zero formal education, once you put on some scrubs, get on your white coat, you are a doctor completely. So those are the challenges. As I said, when we get a reportage, we do spot enforcement on compliance. And you can imagine, spot enforcement and compliance is expensive. The logistics involved in sports, for instance, you are here and somebody reports somewhere in Western North or OT. We don't even have an office in OT. Somebody reports that there's this issue in OT. So we move a vehicle, fuel the vehicle, put in personnel, drive all the way from Accra or the nearest, who I think is the nearest office, to go and close down one facility and come back. So those are challenges, real challenges that we face. But nonetheless, we do that. We try to do that all the time. And then once we are in the region, we move about aimlessly through the markets and the city or town to see if we can catch somebody else. Closure of non-compliant facilities, we've done a few of that. Unannounced visits. we pay a few. Unannounced visits comes under the category where we came because of one facility, but we can't waste our fuel. So we end up, visiting other facilities. And a lot of times it's quite beneficial because we catch so many people. Sanctions and prosecutions. Currently, MDC mentioned the challenge. Our judicial system is quite long. And we understand why it's long. They have their reasons. Another thing is that the judicial penalties are not, hefty enough. So to take somebody through, the agency will spend so much to take somebody through the process. And he mentioned that the police will leave them. So if you don't want the police to leave them, it means you have to be paying frequent visits, reminding them of their case. You look at the fuel, the time, the logistics that you spend, and then when it gets to court, the penalty is so small. So what our law, gives room for us to give fines. So what we rely on is fines. So we make it as hefty as we can, and then we move on to pay for all our logistics. So challenges, what are some of the challenges that we face in enforcement? Evasion by operators. There are some facilities, because they know Hefra is in town, they operate only at night. We've had so many like that. During the day, you scout the entire area. It will be firmly closed, but at night, operations will go on. I've already talked about our resource constraints. I've talked about the legal and procedural delays. And then demand for low-cost care is really, Quackery thrives when there's demand for low-cost care. A lot of the people cannot afford your services, and that's just the truth. I don't think it's only in Ghana that dental care is expensive. When I did a Quackery, survey around nations, it seems to be generally expensive across board. But that means that a lot of the people will be cut off from care, and that is how Quackery is going to thrive. So maybe in your hope and your dream to end Quackery, you may want to review some of your fees and meet Hefra halfway. So what are the collaborations that we can do, with you as an association? We are happy that you are an association, because once you come together, when we want a resource person to help us update our tools, because we've had our tools for quite some time, there are many things that you do now that may not be appropriately captured in our tools. So once you have an association, we know who to invite, and we are not inviting an individual coming in as their own person, but we are inviting somebody who is representing the association and be able to tell us the association's position and the way to go. With you, we can have a broader reach, because you all have your practices, and you have your practices in communities, and in communities, in neighborhoods, etc. You have family members, you have friends who know you as a dentist, so they may visit a place and come and ask you a question, that I went to this place and so and so and so, and so we rely on you to be our eyes where we cannot, see, and report all your findings to us. Currently, the Ophthalmology Association is doing that with us, and so we'll be very, very happy if you could also do that, because they also have a problem with Quackery in their system. Stronger reporting systems. Our number is at the end, it's a landline. One comes directly to my office, so you can always report. You don't need to tell us your name, but you are all, what are you? Gatekeepers. You are all gatekeepers. Culturally, that is how we are. So I'm not going to fault you too much. So we are all going to stay behind and complain. But who to go forward and attach their name to the final complaint, you will not find anybody. We will all stand at the back and whisper. So you pick a phone and whisper to us. You don't need to identify yourself. Let's just continue the whispering process. All we need is the location and the name of the facility. Just whisper to us. Don't leave your name. Don't leave anything. And then we will pay a visit, an anonymous visit, unannounced visit, and see if what you reported to us is true. Now, we also have some people even Well, I was going to say email, but email, maybe we can trace you. But the phone call is a landline. We can't even get your number. It's a landline. So whisper to us. We employ you, please. I think MDC already talked about media engagements to increase public awareness. It's been a long time since I watched local TV, so I don't know if you've been active there, but when we were younger, you were quite active. I think there was a close-up of Pepsodent something moments that a dentist will come and tell us how long we should brush our teeth and there are some few things like that. So if you can continue things like that, don't leave the space for the aesthetics people, for the quacks. They are currently dominating the media space and you are quiet. It's almost as if you are not fighting them. Please, rise up, let us see you, give us the right information. And the more we see that you know your stuff, then you can sway public attention from them and to you. They are all business people. If people are not going to them, eventually they'll fizzle out. Okay, I think we've said basically everything here. Engage wider stakeholder. I think this is for you and for us as well. He mentioned the police releasing them. The police also, they have their constraints. I mean, they have their logistical constraints and things like that, but the major thing is lack of education. When my association, psychiatric association, we wanted to, during the fight against criminalization of suicide, that is when we realized that those with knowledge, we are here, and everybody else is here, and we are just screaming across the room. They have no knowledge. You are the experts. You don't assume that because you've told them to arrest somebody, they understand the purpose of the arrest. You say, oh, this person is doing more than he should do. What does that mean to the police officer? So we have to engage them more. We even had to engage the judiciary because the judges didn't know. And we don't blame them. That's not their area of expertise. It is our area of expertise. So we have to educate, and that is what your association should also do. Engage local authorities. These people are in communities, offering sometimes free service. That's how they get into the community. And for you to tell the community to sack people, giving them free screening and things like that, that would be very, very difficult. So you have to engage them, make them understand what some of these people are doing, the dangers to them, etc. Civil society, traditional leaders, etc. So that there can be like a coalition against quackery in dentistry in Ghana. HEFRA, we are trying. We are doing our best. Strict enforcement. MDC has already thrown us under the bus, so it means that we have to be stricter. Whilst people are trying to enforce, there may be other people are working under to release their family members, because we all know somebody, and somebody is everybody's uncle or cousin or friend. So we also have to do our internal work, improve our surveillance and unannounced visits, data intelligence and targeting. The other thing is the sharing. For instance, the compliance, that is even within the agency and outside the agency. The compliance units will have an information and other units are not aware. So whilst they are doing their visits, licensing is also busy processing the license. So there's no collaboration. Or MDC has an issue, HEFRA is not aware, and HEFRA is issuing license. By the time MDC's letter arrives, the license is gone. So these are some of the things. We have made, I must say, it's not all gloom. I mean, sometimes as Ghanaians, we like to talk about the negatives a lot, and we like to talk about challenges a lot, but it's not, that's also, I think, is in our nature. But it's not all, gloom. We've done a lot. We've made significant strides as HEFRA. I'm sure your association has also made significant strides since you came into being. As HEFRA, since 2011, we've done a lot. We've made significant, and I think that together we can all strengthen the regulatory framework in Ghana. This is our parting words. In case you get your license, you must display it in an open area. We don't hide licenses, with your name boldly on it, so that anybody who comes there will know that you are duly registered. We are currently working on our website to update our data so that when your license is there and a visitor scans the QR code, it will bring the visitor directly to our page to confirm our database, to confirm if indeed you are licensed and the name of the practitioner so that they can ask if you are Dr. So and so. And then we can all, protect the system. So thank you very much. I think together, let's build a healthcare system where regulation is not feared but trusted, and where every facility is a sanctuary of safety for all. Because we all don't know when we will need the services, and what will be left will be a quack. So these are our numbers. The first number goes to our PR units, and then the second number goes to the licensing units. The phone works all the time, Monday to Friday. So please call us within working hours, please. We'll pick it 8 to 5. If you call outside those times, it will not be picked. Thank you very much.
Thank you, Dr. Mafu, for your 5-star performance. It's time for questions, dear colleagues. I'm sure we have a lot of questions that we would like answered. Unfortunately, we have only 10 minutes, and we'll try and get through as many questions as possible. We're also encouraging our friends online to also send their questions. If I can kindly ask our 2 speakers to join us up on stage so that they can quickly answer our questions for us. As they come, I will start with my questions. Dr. Mafu, my first question goes to you. So, first of all, I'd like to commend you for the attempt to employ technology to help Yes, I'd like to commend HEFRA for the attempt to employ technology to help fight quackery. But my question is about your aesthetics clinic, the fight against aesthetics clinic. Has there been any collaborations with the association to help identify what the issues are and to help regulate it? Dr. Piazza-Kodia, you know, a lot of the advertisement is on social media with the quacks. But I also know that MDC frowns on advertisements by legitimate practitioners. And it looks as though we've left the space for the quacks to operate. Has there been any change with regards to MDC's stance on advertisement? Because I think that now the terrain has changed completely. So if you can educate us on what the MDC's current stance is on advertisement by practitioners. Yes.
Thank you. So your question is about aesthetics clinics and whether we've collaborated with the association. The aesthetics clinics came together only recently. In fact, they inaugurated their association, I think about 3 weeks ago, and I represented HEFRA. So they have now managed to put themselves together as an association, duly registered. And it's called GAMP. You can check them out. The Ghana Association of Aesthetics and Med Spa Practitioners. So it was just inaugurated a few weeks ago. So when we were developing the new checklist, that is how come we contacted a few of them. And it was through that collaboration they came together to form an association. So currently they have a proper association working with us, and they have also said that they are concerned about the quackery in their system, and so they will report because they know each other better than we do. So yes, there will be a lot of future collaborations on that.
Thank you very much. But let me just maybe state our position on the aesthetics. In fact, this has come up several times because we have had a lot of people forwarding videos, from social media to us, asking us who is in charge, who is regulating these people. And of course, there is no regulation. So once there's no regulation, then there's no accountability. They just do anything. This is what we are thinking. The discussions have not ended. We are still in discussions. That for us, before anybody could go into this, we consider it as, say, a subspecialty or a specialty. And so, for instance, if you want to do something about the skin, you must first be a dermatologist and then specialize in aesthetics. If you want to do, teeth whitening or whatever it is, you must first be a dentist. By primary training, understand the anatomy, physiology, everything, before you can become that. If we leave it to anybody at all to do, then what it means is that we need to get them some regulator, get them some training, so get a body that will oversee their curriculum and all those things. And we are introducing a lot of things. So that is our position. The discussions, like I said, have not ended. We hope that we will engage more and then bring some sanity in that space. As far as adverts are concerned, the Medical and Dental Council has not changed its, regulation on adverts. What we say is that you can advertise the services you offer in a very simple manner, not in a way to, let me say, have undue advantage over other practitioners. What I mean by this is that you don't do things that will steal patients to you, that will attract patients to you unnecessarily. Because we have had a few instances where people have put, for instance, before and after pictures, and patients have gone and they have not had the same outcome and there are issues. So those are the things we want to avoid. But if you say you do OPD services, you do scaling and polishing, you do this, you do that, without even mentioning the professionals, that is fine. Okay, so we haven't changed it. Unfortunately, these people on social media are not under any regulator. And that is where the difficulty is. Okay, so they do anything that they want. But of course, if we have information, then like my colleague said, we do undercover investigations, make sure we get them prescribing or attending to patients, and then we grab them. And so that is what I would say as far as these are concerned.
Thank you. I'd like a follow-up question, but this is not me alone. So please, if there are any questions. Yes, Doc. Can we please get a mic? And then Dr. Ankara as well.
Saying, some of us have had the opportunity to work with HEFRA for a long time. So we know HEFRA for a long time. So we know some of the things, where HEFRA started from and where it's heading. With regards to the licensing for spas, I think you should have another critical look at it. when you said stakeholders, did you invite any of the dental professionals? Because as Dr. Kodja said, you are dealing with an environment where you have professionals already there. And if they are claiming they know where the quacks are they referring to us? So please, you need to have a critical look at that. When you're going for monitoring, do you have a dental person part of the monitoring? Because I've seen you going for monitoring and there's no dentist or any health professional. So what exactly will you be looking out for? And then your statement of our hope and dreams. Our hope and dreams are in collaboration with our regulatory agencies. So if our regulatory body is telling us our hope and dreams, then we are in trouble. So please, we are here to work together. It's not just about pushing it to the regulatory agencies. It comes down to the Ministry of Health, Ghana Health Service, the professionals, and all the agencies of the Ministry of Health. So we are all in this together with the communities. So I think the invitation by GDA was to have some hope from our regulatory agencies and for us to find a way to work together to tackle this menace. Thank you.
Thank you, Doc. Please, Dr. Ankra had, if we can get some.
Yeah, thank you. My questions remotely relate to Quackery, remotely. And it's based on a statement the deputy registrar made during his presentation. My understanding was they own the various curricula from the medical schools and other agencies that train people to practice. When I say they own, it means they actually review the curricula. And the lady from HEFRA, in her presentation, also stated that they now and then contact the MDC for scope of practice. Having down these background, my question is, I noticed the MDC have a specialist register. Now, what I wish to know, whether they own the curriculum for that in order to license people as specialists. I say this because last week we had a curriculum review at the Ghana College of Physicians and Surgeons, Faculty of Dental Surgery. We went to review the curriculum, and I asked a similar question. I know the Dental Council of the UK, they own the CCST. They provide you with certificate of completion of specialist training. So they own the curriculum, they come out with the curriculum. Is it the case that the college has their curriculum and they present their candidates as specialists and you just register them as specialists? Or you own the curriculum? Can you tell me, please? Thank you.
Dear colleagues, I would crave your indulgence to please keep your questions simple and straightforward so that we will be able to take as many as possible. But my dear speakers, please.
Okay, thank you. So I think the first question was about when we're developing the check list for aesthetics, whether we invited the Ghana Dental Association. You know, Ghana Dental Association and aesthetics is different. The things that they do, the things they do that are under your practice is not, it's outside their scope of work. So the aim of developing a checklist, usually when we develop a checklist, what we do is that we write to the Ghana College of Physicians and Surgeons, and then they provide us with the expertise, depending on where we are going. And then we write to the specific association that we are trying to regulate. So in this case, the aesthetics people. So they also brought their representative. For them, currently, they are now trying to go under TVET. They don't have, as MDC said, they don't have a regulator. So we couldn't have invited their regulator. So that is how we develop checklists. What they do as whitening is only a small part of what dentists do. They do a lot of dermatology things as well. They do a lot of plastic surgery things as well. So once it's not within your association, we write to Ghana College of Physicians and Surgeons, and then we all sit together to look at where should their practice end. So what they are doing is quackery. It's really not something for Ghana Dental Association to come and answer. I don't know if you understand what I'm saying. What they are doing is quackery. We are not endorsing it. What we are trying to say is that for aesthetics, what are they supposed to do? So the college provides us with experts, and then we develop. We say that in order to do aesthetics, this is the expertise you must have. This is the certificate we must check. And this is your scope of practice. So if they do whitening, it's not part of their scope of practice. And that is where enforcement and compliance comes in. Your second question was about monitoring. You know, HEFRA has evolved. Every regulator, every association, you start with some objectives. And as time goes on, you realize that you need to improve. You need to change certain things. Initially in HEFRA, even inspections, they said, well, I wasn't there at that time, but they said it was difficult to get dentists. So they used to, even when they are inspecting dental facilities, they used not to go with dentists. But currently, every dental facility that is inspected, the lead is a dentist. When it comes to monitoring, monitoring is a bit different. When you go for inspection and you check all these things, you write what their shortfalls are, and that is the goal of monitoring. When we came, you didn't have this, you didn't have that, you didn't have this, you didn't have that. And that has already been provided. So that is what they go to check. Have those things been implemented? And then, of course, they check other regulatory things, whether you are within your scope of practice and things like that. I think that for the last one, in my presentation, I already said that we collaborate, and we hope to collaborate with you. So, thank you.
All right, so let me take mine. The statement I made as far as the curriculum is concerned is a statutory function of the Medical and Dental Council, that we look at the facility, the curriculum of training institutions in Ghana. And so for all medical, we will set the minimum standard at which we think we should train our health professionals. Then the institution may decide to add a few things depending on their statutes as universities or schools. That we do not interfere. But once we are mandated to set the standards, we need to make sure that these are internationally matched, benchmarked as far as the training is concerned. Having said that, the Medical and Dental Council was set up by an act. In the same way, the colleges were set up by an act and given a specific mandate. And so we don't veer into specialist training. That is reserved for Ghana College of Physicians and Surgeons. And then, of course, you have the College for Pharmacists and then the nurses and all that. That is their area.
So we don't venture there. But as far as undergraduate training is concerned, that is within the domain of the Medical and Dental Council, and that is what we do. We do not have curriculum for specialist training in Ghana here. That is totally within the reserve of the college. But once you have trained, and they who have the capacity to determine whether you are actually a specialist, say you are, and they have given you a certificate, then we have to register you, because you cannot practice in Ghana, whether dentistry or medicine, without being registered. And so once you have the certificate, then we must register you. The certificate alone does not guarantee your practice. You must be licensed, registered and licensed before you can practice. And the law is clear on that. And so once you get your training over there, bring your certificate after your graduation or whatever, then we can register you as a specialist. Now, we are registering you as a specialist because of this scope of practice thing. People are practicing in our hospitals beyond their scope. And so we want to be sure that once you present your certificate to your employer, they know truly that you are a specialist or not. We introduced this some years back. We have enforced it to a certain level. Now it is free to register as a registrar. Going forward, we are going to make it mandatory. If you are not, if you are a specialist and you don't register on the specialist register, then we will not know you as a specialist. So for instance, if something happens, you get maybe an employment somewhere, contract somewhere, and then they are requesting for us to testify whether indeed you are a specialist. It is what is on record that we will give them. No two ways about that. So these things we do are in your own interest. And then if you say you are a specialist, somebody will say, why are you not on the specialist register? Okay, and then they can take you on the legal route. So it is in your interest as a specialist to register with the council as a specialist. But that does not mean that we have a special curriculum that we have developed for specialist training. We don't deal with specialist training at all. Thank you.
Please, we'll take two more questions. There are also a couple of questions from our online audience. So with your kind permission, I'll read two of those questions. So from a regulatory point of view, what drives Quackery, and how can the association help to curb it? Both Alex and Alberta can help answer that one. And then this goes to Alberta. Can somebody be employed full-time in a government facility and still register a private facility?
I'll start with the second question. No, the law does not permit that. In order to be a PIC, a practitioner in charge of a facility, you must be a full-time employee of that facility. So you can't be a full-time employee of a government facility or any other private facility and try to be a full-time employee of another private facility, because you are solely responsible for everything that's going to happen in that clinic. So if you are not a full-time employee or you come there as and when, then you are going to be found wanting. And that also means that a lot can happen on your blind side whilst you are absent. And that's when you introduce other people to perform things they are not supposed to perform because you are not available. So the short answer is no.
Yeah, so just a word on that. We think that double practice, when I say double practice, full-time practice is not even possible. Okay? Of course, you can be part-time in other places. So you cannot, if you register as a practitioner in charge, we hold you ultimately responsible for everything that happens in the facility. And you cannot be in facility A working full-time and then at the same time register a facility as the one in charge. It is not practical. So please, it is a no, no, no. We have had a few instances where practitioners have had to siphon patients from public facilities into their own facilities. And things have happened there. And they are in big trouble. And it is becoming, quite rampant. And so let me please sound this caution to all of us. If you practice in the government institution, please do not go and use your license to register another facility. And do not steal patients from the public institution to your private institution where you know you don't have the needed resources to take care of patients. And then you go there, something happens, you refer them back to the same facility where they should have been in the first place. We are dealing with a lot of such cases, at our end. And I want to sound this caution to all of us to, desist from doing that. Drivers of Quackery, I think we have mentioned that there is access gap. There is, affordability of care, convenience, and all those things. Fuel some of these things. And then we ourselves as practitioners, because we want cheap labor, employ people who are not in good standing to do the work for us, okay, so that we can pay them pittance and then get the maximum profit, okay. And then because we practice in different places, we need to get somebody to replace us. And most of the time, we can't pay as much as a qualified dentist would take. And so we resort to, getting somebody who is not qualified or underqualified, and then empower them, teach them to do what they are not supposed to do. So these are the things that I think drive Quackery, and we need to also work on ourselves. Thank you.
Yes, Dr. JB, please go ahead with the online questions.
Mission the clinics without MDC's attention. That is one
Please
question.
Repeat your question again.
How does HEFRA help commission the aesthetics clinics without MDC's attention? That was one. And the other question is, how can HEFRA give out the scope of the aesthetic group? The scope of the aesthetic group. And then the last is, did they expertise on dental care from GCPS in generating the checklist regarding whitening? Those are the three questions I have from YouTube.
Yes. Okay, so I think the question was, how did HEFRA inaugurate? Was that the question? The aesthetics clinic without MDC. HEFRA didn't inaugurate. HEFRA cannot inaugurate. The association came together, just like your association. A group of people came together and decided that they want to put your professional body together, and then registered it and did all that. So that is what the aesthetics group did. And then they invited HEFRA. You must know that HEFRA has been licensing aesthetics clinic for quite some time. Unfortunately, we didn't have a specific tool for aesthetics clinics, and that is what we've worked on currently. So we didn't inaugurate them. And then you said without MDC, aesthetic practitioners are not regulated by MDC. So MDC really does not come in here unless the group decides that they want to invite MDC. They currently, personnel practicing aesthetics and med spa currently are not under a regulatory body, the personnel themselves, but the facilities are under HEFRA. So let's try and differentiate the two. MDC regulates you as dentist, but your dental clinic is regulated by HEFRA. So there's a complete distinction between the two. So even though they do not have a regulatory body, the personnel do not have a regulatory body currently, the facility has a regulator, and that regulator is HEFRA. Then, I think the second question says, did we invite the physician and Ghana College of Physicians and Surgeons when we're developing the dental checklist? Was that a question? Please, the one who read, yes. What is GPS? What is GPS? Okay. So, and because I said Ghana College and you said GPS. Okay. Regarding specifically just whitening. So when we develop our checklist looks at services under a facility. We don't look at, we don't regulate single services. I don't know if I'm getting the person's question correct. So what we look at is that under this, MDC provides us with a scope of practice if the practitioner is regulated by MDC. NMC will provide us the scope of practice if the practitioner is regulated by NMC. Allied Health will provide us the scope of practice if the practitioner is regulated by Allied Health. So MDC currently has two groups or three. Okay. So those that can be PICs are doctors and PAs. So MDC will tell us that for a dentist, this is how far a dentist at this level can go. If the person is a maxillofacial surgeon, this is how far the person can go. If the person is a PA, this is just how far the person can go. And how far the person can go, the scope of practice gives us the services that you can offer. So we look at the scope of practice to determine the services that the practitioner, based on their level of training, can offer. So, for instance, when we were developing the checklist for dental clinics, that was many, many years ago, and we wrote to Ghana, the College of Physicians and Surgeons, and they brought their rep. They then told us that per their training, because they train specialists, so per their training, a specialist in this area can do A, B, C, D, F. Then when we go to MDC, MDC regulates PAs. We have oral centers, oral health centers, that's what we call them, and that is manned by PAs. So MDC will tell us that for PAs who want to go into oral health centers, this is what they can do, A, B, C, D. And so whitening, once whitening is not under your scope of practice, whatever you are doing involving whitening, you've gone beyond your scope of practice, and that is a sanction. For instance, I think when I was presenting, I mentioned that we had a facility somewhere in the Nzema area, and the person is a PA, and he was doing tooth extraction and things like that. So that is beyond his scope of practice. So as soon as that happens, then sanctions come in. But we don't say that, we don't look at individual services and say, if you are doing whitening, you must do this, you must do that, you must do that. That's not what we do. I think there was a third question now.
Dr. Newman, I'm really sorry, but our time is up. But this is not the end of the discussion.
Oh, it's a follow-up to what I asked her earlier on.
I know, Dr. Newman, but as we step off, we can have this discussion. And that's what I'm actually hoping will happen, that we continue talking about this from now on till we are able to get to a place where, okay, I've been told that we can allow 2 more questions. Okay, so Dr. Newman, please go ahead. And then Dr. Katu, yes.
Yes, so yes, our head of licensing from HEFRA, I understand from what she was saying that HEFRA is licensing the aesthetics group. Now, HEFRA stands health facilities, health. So in this sense, are we putting the aesthetic group under health? And if they are, what cadre of staff are there? And if you have doctors there, then MDC should be in there. if you have nurses, the Nurses and Midwifery Council should have regulation or regulate the staff in those facilities. So I just want that clarification. If you don't have them, then please, can we have whitening and the braces out, because that is for dental. Thank you.
I think that in spite of all my explanations have been misunderstood. I try very hard to tell you what a scope of practice is. An aesthetic clinic, whitening or dental practice is out of their scope of practice. That's why I keep on telling you that there's a scope, please, there's a scope of practice. Currently, what you are seeing is quackery. So don't base your questions on quackery. I don't know if you understand what I'm saying. Initially, what HEFRA was doing was Initially, what HEFRA was doing was to regulate aesthetics clinics as health centers. And then we realized that, in my opening statements, I said that we are evolving. No regulator is perfect. Your association is also not perfect. There are a lot of changes that you keep on doing based on things, emerging facilities. When HEFRA started, there were no aesthetic clinics. There was nothing like that. There has been a proliferation of aesthetic practice in recent years. And so when aesthetics came up, in order to develop a checklist, there's a whole process that HEFRA goes through. The ministry has to come in, a whole lot. And the registrar at the time thought that this process is going to be long. You can't leave these people unregulated. Because if you leave them unregulated, then there's going to be a lot of problems. And so he determined that we are going to look at aesthetics as a health center. So we were regulating them at that level as health centers. And then a few years ago, doctors started entering the practice. And once doctors enter a practice, the level of the facility upgrades. You cannot level a facility that a doctor is in as a health center. So we went back to the drawing board and said that health center, the checklist that we have for health center is too generic. It's not fit for purpose. You must know that even for dental and things like that, they are breakaway. Now people want to set up maxillofacial centers. We don't have a tool like that. So once the specializations increase and they are breakaways, we have to develop checklists. So initially there may not be a proper checklist, but eventually there will be. So yes, so we decided that, the registrar decided that this is no longer fit for purpose. So we need to develop a proper tool for aesthetics so that we can clearly define what they can do and what they cannot do. You are not the only people with this concern. Dermatologists have the same concern. Plastic surgeons have the same concern. And the agreement is that if a normal doctor cannot man a specialist clinic, for instance, you cannot say that you are a dermatology clinic and your PIC is an MO because they don't have the qualification for that. So if a normal doctor cannot man a specialist clinic, then certainly a normal doctor cannot man an aesthetic clinic. So if you are a doctor, then you must have extra training in the field that you are going in. And currently, we have doctors who have gone to specialize in aesthetics. And when it comes to facilities, that is why we've separated them. There's med spa and there are aesthetics clinics. They are not the same. Let's not confuse the two. Aesthetic clinics have a different PIC. That is where you have your medical doctors and things. That's the line they will toe. And then we have med spas where you have people without the necessary specialization going. Currently, the last hurdle for us to outdoor the checklist, we haven't done that last hurdle. So I cannot tell you what is in. I think somebody asked that question. I cannot tell you what is in and what is not in. When the stakeholders meet and they develop a tool, the stakeholders have to meet again and look at it and say that, yes, this is what we agreed to. Or maybe since we went, there's this new development, so remove this or add this. That has not been done. So that is not a final, checklist for me to tell you that this is there or that is not there or that is not there. But once whitening, braces, braces and things like that, for the scope that we have, that we've worked with College of Physicians and Surgeons, what is not in is outside. But until you bring the proper checklist, we as a regulator, if you're going to regulate something, somebody, it should be based on something. So once you have your proper checklist and you go to a facility, then you say that you are going out of your scope of practice. We all met and agreed that this is outside your scope. So what you are doing is quackery. And that's where enforcement and compliance comes in. So we understand your sentiments. It's not as if we don't understand. The challenge is even bigger for us because we've been slow in acting. And it's not only your space. We have home health services. Now people want to even go to people's house to go and do dentistry. It's a whole lot. And we are doing a lot of catch-up. We were quite slow, but now we are doing catch-up. Telehealth is also another area that we are struggling with. Now assisted reproductive health services is also a big area. A whole lot is going on. So regulators are trying to catch up. It's just that innovation of services runs faster than the regulator can, at the moment, catch up. But we are catching up. Thank you.
Can I just make a comment on this? Oh, yeah. So it is true. Regulatory activities are outpaced by the rate of innovation and technology advancement that is coming up. And so sometimes we face challenges as regulators. But I believe that if there is any aspect of health that is being practiced in this country, we expect the practitioners to fall under a certain regulatory body so that they are regulated. And so if it is a direct service the person is doing to patients, then, for instance, if it is about removing somebody's tooth or something, that is considered an aspect of dentistry. The Medical and Dental Council should regulate this person. If it is something that is of assisting the professionals in question to carry out the service, then you can say they should fall under the allied health and professional service. So that at least somebody is looking into the services they provide. So if we, for instance, sanction or, as it were, credential their facility, when we don't know the regulatory body, the professional regulatory body that they fall under, how are we going to regulate their activities? It becomes complex. And that is why I said that we should tread cautiously. If it is something that falls under dentistry directly, providing service to the patient, it should come under Medical and Dental Council. If it is assisting the professional to offer service, like your dental surgeon assistant or something, then allied health, for instance, so that we don't leave any, place unattended to create more problems for us, because there are a lot of things going on that if you don't take care, we will be overwhelmed. And before we realize, things have gotten, out of hand.
Thank you, Alex. Dr. Kato, that would be our last question. Please go ahead.
Okay, thank you very much. So please, my question is about the PIC. As a private dental clinic, if you have a PIC with a dental background, and now you want to introduce medical services, do you have to change your PIC to a PIC with a medical background? Because it seems like we are facing something like that, and I want you to explain it to me. And then you mentioned the DIMS. So with the DIMS, yes, you mentioned the DIMS. I realized that most of the time the data that is captured for dental services is very, very low in Ghana. And then we see a lot of cases in the private clinic, yet it's not captured in the DIMS. So our impact is not really realized in especially when you want to push for policies and those things, they can't tell our impact. Is there any way to link the DIMS to such that the private clinics can enter their data at the end of the month, just as the government facilities are doing so that we can actually see the true picture of the practice of dentistry. Thank you.
Okay, thank you. So for your first question, once you register as a dental clinic, so the first time you were a dental clinic, your services is specific to a dental clinic. The minute you introduce something else, then you cease being a dental clinic. And so then the next available will be a general clinic, because it means you've added other things to it. So we will license you as a general clinic. And a dentist cannot be the PIC for a general clinic. So you need to get a medical practitioner for that. I mean, you understand what I mean? Yes. The second thing is the DIMS2, reporting into DIMS2. Private facilities actually do report into DIMS2. DIMS2, I think, sits with Ghana Health Service and MOH. So I will contact them to assist you. But we know other facilities, other private facilities that report into the DIMS2. Yes.
Ladies and gentlemen, dear colleagues, from our reactions, it shows me that we are really passionate about this, and we would really want the different agencies to collaborate with us so that we can get better at this. The thing about dentistry is that it's an art, a science, and a business. And so it's a little more complex than some of the other branches of medicine that is there. And so our problems are quite unique, and we have to find innovative ways of solving it. But let's not let the discussions end now. In fact, let it be the beginning of the discussions to try and get the best way possible to reduce quackery. The thing is, it affects us directly, our reputations, our images, and if all of that doesn't matter to you, then remember it affects your pocket as well, and that should also matter to you. Thank you very much for your attention.
Doc wants to help answer the questions for the DIMS, so a minute. Sorry.
Yes, sorry. I just want to answer the question with regards to DIMS.
Yes,
So
if you
I'm
can make
helping
it
out
very
Doc.
quickly,
Yeah,
I would
so
be glad.
Just as she said, every facility is supposed to report into the DIMS, and it's something that HEFRA actually insists on that. Now, the DIMS sits with Ghana Health Service. For private facilities, because you don't have the health information officers, what happens is that once your facility is within a district, you are supposed to report to the district. There's a form, you fill it, and then you send it to the district, and the district enters it into the system. So there's a way for it, and there's a format for it. So your district health directorate is where you're supposed to report the data to the DIMS. And most facilities are not doing it, especially the private ones. They are not doing that. So like she said, we are losing data, and that affects when it comes with policy and getting facts to back what we want. Thank you.
Thank you very much, Dr. Newman. So, Mr. MC, with your kind permission, my job is done. Thank you.
Let us give a round of applause to, please don't be in a hurry. Just give me a second. I think that our presenters have done so well. We appreciate the presentation and the session. Madam President, please do me the honors to give our appreciation to our facilitators. Dr. Alex Piazza Kudia, the Ghana Dental Association, on their 35th Annual General Conference, appreciates your presentation. This one is not quackery. This is proper. Madam President, don't be in a hurry to go. The next one, Dr. Alberta Insia Asamoah Mafu. Long one. Doc, which one is the surname? Thank you. On behalf of the association, to you and your boss, Dr. Ban, we appreciate your presence and your presentation. Thank you very much. Thank you, Madam President. I'll call on Madam Chairperson, LOC. Dr. Sylvester Owusu, on behalf of the Ghana Dental Association, for helping us moderate the first scientific session. The GDA appreciates your effort. Thank you very much. On that note, on your behalf, I duly discharge our panelists. Thank you very much. We appreciate it. I will push us straight into our next session for the next presentation. We've done a little swap. We are going to take one more presentation in the next session. But to moderate this session for us, our moderator during the day is a restorative specialist. And by night is an author. In the day, she does restorative dentistry at the Department of Dentistry, Ho Teaching Hospital. In her role as a head of department, she oversees clinical services and mentors junior officers engaged in outreach programs. She has a strong interest in preventive dentistry. At night, she writes books for children and young adults. She has 20 published books to her credit, with stories that blend adventure, Ghanaian culture, and life lessons. Through her writing, she promotes literacy, self-confidence, and health education among young readers across Ghana and beyond. Join me, welcome Dr. Ruby Yayira Goka to moderate the next session for us.
Good afternoon once again. Because of time, we'll just go straight into the second session. So the profile of our first speaker for this session. Dr. Emmanuel Morris Ankara is one of Ghana's foremost medical legal practitioners. He brings to the bar a rare convergence of clinical expertise and legal acumen that has defined his distinguished career. My apologies. So we'll be taking our second speaker first. So as our first speaker is Professor Robert Ebo-Hinson. Professor Robert Ebo-Hinson is a distinguished marketing scholar, higher education leader, and branding and marketing strategy consultant with over 3 decades of experience in academia and industry. He's widely recognized as Africa's leading marketing scholar and Ghana's top business and management academic, according to the AD Scientific Index. He holds a DPhil in marketing from the University of Ghana, a PhD in international business from Aalborg University Business School, Denmark, an MBA in marketing, a BSc in marketing, and is a chartered marketer. Professor Hinson currently serves as a professor at the University of Ghana Business School and and has held several senior leadership positions, including Pro Vice Chancellor of Ghana Communication Technology University, Vice Chancellor and Deputy Vice Chancellor of the University of Kigali, Rwanda, and Rector of Perez University College, Ghana. He also serves as a distinguished visiting professor at the University of Johannesburg, South Africa. He's a prolific researcher and thought leader. He has published over 150 peer-reviewed journal articles and book chapters. He's authored or edited more than 45 books and monographs, and has received over 8,700 academic citations. He's the recipient of 3 prestigious Emerald Literati Awards for excellence in research. Beyond academia, Professor Hinson has consulted for more than 200 organizations and brands across Africa, providing expertise in marketing strategy, branding, customer experience, sustainability communications, and digital transformation. He's also a sought-after keynote speaker, contributing to discussions on marketing leaderships, ESG branding, customer experience, and Pan-African business strategy. His research interests include marketing and brand strategy, service management, corporate social responsibility, sustainability, digital transformation, ESG branding, and communication technology management. Today, we are privileged to have Prof. Robert Ebo-Hinson speak to us on multi-sector collaboration in the fight against quackery. Thank you very much.
This is a disastrous photograph from 7 years ago when I was 24 kilos heavier. I sent the Holy Child trained president a proper photo of me today. And then she decided, because she doesn't like Achimota school, that she'll use the photo from when I was careless about my food and when I wasn't so disciplined in ensuring that too many carbohydrates don't enter me on any day of the week. That said, let's clap for Dr. Kakraba Kwashin. So, if you know me and the way I speak, I can't stand in one place. So can you go with me? I'm going to come down. Is that okay? All right. So, I'm here in the stead of the absolutely accomplished Joel Edmonete, who was supposed to come and speak here on the topic I'll speak on today. Joel has been my friend for 41 years. When I went to Form 1 in 1985, he was in Form 2 in the famous Achimota school. So when he called and he said he couldn't find anybody to come in instead, and he thought I'd be appropriate for the job, I had no option but to say, yes, Charlie Maya, Maya, Maya. When I was saying the Maya, 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 I had no space on my calendar for this. But when I realized your president went to Holy Child as well, then the deal was sealed. Because my wife went to Holy Child. Clap for Holy Child School. Okay, all right. So, I have the most fascinating topic to speak on, and I'm sure the slides will come up soon. But after I sat here, I was filled with a bit of trepidation and anxiety because when we speak about quackery, even in this room, there seemed to be some contention around who can do maxillofacial something, who cannot do maxillofacial, who can remove teeth, who cannot. I said, wow, what a confusion, you know. And there are over 45 scriptures on teeth in the Bible, and I was looking at a couple of them, and one of them is from Psalm 124 verse 6. It said, blessed be the Lord who had not given us as prey to their teeth. So this, your teeth, is a very powerful thing. Because charlatans can kill you if you take your teeth and then you give it to them. So, what should I do with this? Up and down. Congratulations. So, I took notes and I was very scared. Let me read some of the things I wrote. They said, we'll go undercover. Then we'll catch them attending to patients and then we'll grab them. Did you hear that? You remember that part? The grabbing part. Another one said, Don't advertise in such a way that you get undue advantage over other practitioners. That one confused because I didn't know which type you can use for you not to get advantage. Then the example was that some people advertise before and after. Then when you go there, after is not as splendid as the advertisement. I didn't know how that example was an explanation of the first one, but it doesn't matter. Then another one was, don't siphon is like petrol. Don't siphon patients from public facilities into the private sector. Things have happened and the people are in trouble. Do you remember that one too? Yes. Let me give you a few. He says, for some people, whitening of teeth and braces is out because that is for dental. Then they said, an aesthetic clinic, whitening is out of your scope. Then he told people, don't base your observations on what is not correct. I said, wow, I was just listening. Then he said, once specializations increase and we have breakaways, then we need new checklist. Then they said, innovation goes ahead of the regulator and is faster than we can contend with. So I'll start from that, faster than regulators. Why is this the anthem of several regulatory agencies in Africa, that innovation is going ahead of them? So every time they must go and chase. Why can't you go ahead of the innovation? Is there a law somewhere in the Bible that says, thou shalt not go unless the innovation goes? No! So if we really want to address this issue of quackery, the first thing we must establish is that the regulators themselves must have tremendous innovation capacity. Because quackery, when it's identified, must be dealt with quickly. But the speed of the dealing with is a function of Ecclesiastes 10:10. The Message Bible says, use your head, more brain, less muscle. If you like, check it right now. And the more brain is the innovation part. So, Madam Holy Child, I'll do it quickly and go. I have to be in another meeting in 20 minutes, so I trust God to do this quickly. So I'm going to set the scope. I'm going to talk about quackery because, I'm wondering how you can take your teeth to some quack. They can kill you, or you don't think so? You can die from quacks when it comes to dentistry. So I think that to address this issue, we need coordinated action across several sectors. So the main thesis I bring today is coordinated action across several sectors. So this is the outline of what I want to do in 20 minutes because I gotta go. Okay, so I'm talking about the problem landscape. Then because I come from a marketing communications background, I'll speak about what the media can do, public education, building trust and communication. Then I'll propose a way forward. Okay. So I did some quick back of the envelope research and I came up with this, that 60% of those who want good dental work, of the population we have in this country, there's still limited dental facility access for those in rural settings. It is what it is. Then, 1 in 3 patients are being misled because they can't distinguish a licensed dentist from an unlicensed practitioner. Apparently, the oral health chaps are not really dentists. It's a whole, it's not easy at all. Okay, all right. Then there's online quackery. You can be deceived online very easily. And online deceit can actually go faster than in-person deceit. It can go quick. So why do we need multi-sector collaboration to handle this? Because in my humble estimation, no one institution can handle it. Even the regulators say the innovation is traveling faster than them. So you that you are in the core profession too, you must believe God to offer some education. It is what it is. And in Ghana, we have this very negative attitude where if you find somebody doing something irresponsible, we don't feel compelled to say, hey, what you are doing is not correct. So it's like live and let live. If we continue with that, we can't weed out quacks. We must speak up and say what is right. Okay. So I'm going to share with you 5 or 6 pillars. I forget how many I put together, but I think these are the pillars that can help to change the narrative and shape perception regarding what the appropriate thing should be. Number 1 is the media pillar. My friends like Bernardino Avila and Kwame Sefaka and co, They can lead a concerted charge to ensure that there's an amplification of stories of harm caused by quacks. Sometimes the deterrence is from how severe the negative consequences. When you hear it loud enough, you repent and you go to the wrong places. Then you can profile licensed trusted practitioners. I have a show on Metro TV called Titans and Trailblazers. It's on Wednesdays evenings from 9 to 10. If you are here, you have dental practice, come, I'll interview you so that we can preach the gospel of regular dental practice. Is that okay? Oh, you mind me? Is that okay? If I say amen, you say that it's not a church. Okay, no problem. then we need to share correct information on good dental practices. Pillar 2, health journalism. So journalism is broad and useful, except there are specialized areas in journalism. So I think what you could consider is training a cohort of brilliant journalists who have base training. Remember, the guy here said, you need to have core training in the area. You can't just wake up and try and do certain things. When he said, I was thinking of myself. In Ghana, every joker is a marketer. I don't even know what to do about that. But that's another story for another day. Okay, all right. Responsible health journalism is a professional discipline. You require accuracy, you require context, and you require ethical sourcing. So this particular one, I don't know who will promote it. But if you can work with a cohort of journalists to build the critical knowledge core to send out the appropriate messages, I think we can begin to move the needle on the matter. Is that okay? Let me start. You look like the two of you are correct. Is that okay? Yeah, God bless. That is why. And let me just stay here. The black and white should have told me something. The rest, they can do what they like. I'll just continue. Okay. So please, good health reporting. This is what it should look like. Listen, the story isn't just the man loses his teeth to quack people. It is, why did he go there? What prevented him from going elsewhere? What systemic change would have saved him? This is the story that moves policy. You know, in life, framing determines a lot of things. So we must learn to sharpen our framing capacity so that the stories will be told in such a profound way, action will be taken. So health journalism that work drives change. It's not just reactive, it's investigative, empathetic. You know all those documentaries we do with undercover people in this country? I think we need one massive one on quackery and fakery. What do you think? Yes. They will out them. They will publish them. Then they can repent. 1 Timothy 5:20, the B part says, them that sin repeatedly punish openly, that the rest may stand in fear. So when we use that, the people will repent. What do you think? Amen. Okay. All right. Pillar number 3, Holy Child School. Public educations on oral health. I think for that one, even Pepsodent is running brush twice, something a day. Yeah, I like Pepsodent very much because of that. Awareness is the first line of defense. When communities know what licensed dental care looks like, what it costs, where to find it, they are far less susceptible to the promises of quacks. So my question to you, Madam President, is, whose job is it to run these world-class public education campaigns? Is it the individual dental practices? Is it you? Is it the Ghana Health Service? Whose mandate is it? Because this totally matters. And effective public education must be culturally resonant, locally delivered, and sustained over time. So I just want to beg whoever can make this happen that we need strong public education programs. We can have a Know Your Dentist campaign. We can do school oral health days. We can do community radio blitz in Hausa, in Akan, in Ga, in Ever, just to try and push the needle on the matter. Number 4, countering misinformation and false claims. So, I've been to school quite a bit. You had a long time to reading about me. But even I'm not too sure about certain dental. I can't know maxillophilial from normal people. I like that word. So I'll take it somewhere. You know, from here, I'm going to do top intern. I'm going to do a recording at 2 o'clock, and so I'll use maxillophilia. I say, hey, do you know a maxillofacial rather? Yes, do you know maxillofacial? I'll use it when I go. It's my best word for today. Maxillofacial. It's very powerful. So please, the maxillofacial must come out so that those who are parading themselves and are prophets of fakery, we will deal with them. Do you know Ghanaians don't know how to be confrontational in the face of evil? We'd rather be diplomatic, let sleeping dogs lie, and speak in a very undertone matter to an issue that's almost cancerous. We don't like doing that. So please, I think you need a new boldness. Proverbs 28:1 is very clear. It says that the people who are not correct, they run when nobody is coming. But the righteous, they are as bold as a lion. That's what you need. Boldness to counter the fake people so that repentance will come. Okay. So we need content libraries. We need platform flagging. If on Twitter there's a fake institution, the correct people can go and meet them on Twitter and say, oh, what I say again? And then we can take it out. We need to, madam, why are you frowning? Did you go to Holy Child? So why are you doing that? Or you went to Wesley Girls, the way you are behaving. You are smiling. Okay, all right. Okay, I thought you were a Wesley Girls person. Okay, no problem. So this is the anatomy of a dental misinformation cycle. The false claim is posted. Then it trends community engagement and social media advocacy. I have like 30,000 followers and connections on LinkedIn. I don't remember the last time I saw anything dental in my feed in the last 10 years. I don't know whether it's going on, but I have CEOs in my network. I have solid doctors. I have vice chancellors. I have directors of marketing, directors of procurement, directors of human capital. I don't remember the last time I saw anything profound that's being passed along regarding oral health, oral whatever, and proper dental practices. Look, you have to be serious about promoting what is right. Serious. Serious. I do crazy advocacy for marketing because it's one of the most misunderstood subjects on earth. So I'm in the center every day explaining marketing is not sales, marketing is not advertising. I'm always in the center because the thing needs help. The way I head the to and fro from the panel to you need help. I've done the diagnosis on my notepad. You need rapid health. You need emergency care. We need to stabilize you before we can go for it. Actually, what school are you there? So short form videos will help. Live Q&As will help. Hashtag campaigns. Real is good. Stop fake. Hashtag fakery kills. Oh, if you go Quackery kills, and it trends, repentance will come. It is what it is. Please, are you following me? Am I making sense? This your response is very lackadaisical. I want some enthusiastic responses. Influencer partnerships. As for this one, okay, you please, I've added it. Get some good influencers to help you. Community champions at Chimota School. Go to churches with 27,000 followers on a Sunday and tell them that if you go to fake, you will die. Don't go to fake. So look for community partnerships, faith communities. Go to mosque. Go to the Ek Temple in East Legon. Find some Buddhists. Go and tell them. You know, pastors are some of the most powerful people on earth. When they speak, the congregants listen. If they speak for you, you are in good stand. If they speak against you, bad things can follow you. So we need the Quackery people to be on the bad side. They will take them to the pastors to say something. Achimota School, are you there? Fantastic. Okay. Market and trade associations. Then chiefs. I heard Otunfo saying in the last 24 to 48 hours that don't come near KNUST land. It is vested in us. If you touch it, something bad will happen. We need Otunfo to say such things. Also about the quack people and the fake. Boss, you are laughing. Don't you agree with me? If Otunfo says, don't follow fake, who won't follow fake? Good to see you, sir. Number 6, licensed. You see, I put the difficult one last. Licensed practitioners. Please, amongst yourselves, can we do a certain disentanglement so that there's clarity regarding scope of engagement? I think that if we can sort that out as practitioners, it will help greatly in educating the populace. But if there are crossovers, and I'm not talking about, I'm talking about going outside your scope. This is very different from you have no training and set up a shop in Jowulu. No, I'm just speaking about disentangling what you do. So when there's clarity about oral health, even the maxillofacial, that one is for, is there a certain type of dentist who can do it or what? A high one, like very high. So there's low, medium, and high dentists, correct? The way they were talking is some dentists can't do certain things. So there's low dentists. So please, we need to know general dentists, which are specialists. Okay. We need to know who the specialists are, who the general practitioners are. An obs and gynae specialist is not a dental specialist, are they? No. So please, we need you to disentangle yourself, please. When you finish the disentanglement, then we need to know who the authentic people are. Then we need to know how we can relate to them. In many communities, the preference for quacks over licensed dentists is not ignorance. It is rational response to perceived cost barriers. You are expensive. Distance, you are far. Look at this one. Cold clinical environment. When we come, you don't make us happy. The quack people, they know how to smile. They know how to tell them we love you to work. But you, when you come, the way you have done your face is a deterrent to the consumption of the service. Oh, should I lie or should I speak the truth? But you came and speak the truth. The way I look at me, you go and do what you are doing. I'll finish and go. And then fear of judgment. It is what it is. If the fake person will not judge me and tell me, why did you wait so long to bring this your rotten teeth? They will go to them. At least they will look at the teeth. Even if the service is suboptimal, they look at the teeth. You hire a mighty high-level dentist, level 27 dentist. When we come, you are preaching all over us and making us feel as if we are bad patients because we came late. Late or early, we are still here. Your job is to assist us the best way you can, so we'll get favorable outcomes. It is what it is. Achimota School, are you there? Patients do not abandon licensed practitioners because they prefer quacks. No. They abandon them because the gap between what is needed and what is accessible sometimes becomes too wide to bridge on their own. It could be a cost barrier. It could be an attitude barrier. You know, I just left the vice president's office, and on the 8th of July, I'm launching a book with the famous chief of staff, Julius Debra. The book is called Citizen Experience, a reset for superior public and civil sector delivery. And in the book, the thesis is very simple, that for so long we keep complaining about people's attitudes. So the book says no more complaining. We give concrete steps for better access, better care, better respect, more circumspection, the way we engage. That's what the book is about. One chapter discusses something called the God principle. You know, when we go to God, we go to somebody who knows everything. Public sector agencies, because of their monopoly, are like God. We have no option. Water is water. Electricity is electricity. This is that. So when you go to God, whatever God says, you take it. The problem with the God phenomenon is that you can maltreat people because they have no option. They must still come to you. That should not be the portion of those who are licensed dentists. No. You should be the most caring, the most welcoming, the most perceptive, the most knowledgeable, so that when the customers come, they don't feel they've come to God. It becomes a problem. So we don't need the God factor in your practices. We need warm, humane care and superior customer experiences that bring them back over. And after all, the fake people will not disappear. They'll still be there. But if you treat them so well, they have no option. Let me tell you, see, in life, whoever delivers a premium service can charge a premium charge. It is what it is. I charge $4,000 a day to speak. I charge $2,500 to speak for the short period I'm speaking. Holy Child says she can't pay. But because of her secondary school, she got a pass. Holy Child is a very powerful thing. Point I'm making is that even if you charge a premium, please, the way I spend, did you go to St. Augustine's? Mr. Whitebeard? No, say, where you know Augustine's? No, the guy behind, no, the guy behind you. With the silver fox, yes. Sir, were you in St. Augustine's? Yes, please. Were you in St. Augustine's College? Congratulations, sir. Okay, all right. At this school also works. Very, very pleased to meet you, sir. Okay. So, every interaction you have at Chimoto School, it must be a trust-building moment. In every service encounter, madam, you have 10 to 15-second opportunity to make a first-time positive and lasting service impression. When you succeed, we call it a moment of magic. When you fail, we call it a moment of misery. Thing is, when you open your dental practice daily and you close and you go home, try and do a ratio analysis of how many moments of magic you created in comparison moments of misery. You know how well your dental practice is doing. 10 to 15-second opportunities every day to create a positive and lasting first impression. They are called moments of truth. When you win, it's a moment of magic. When you lose, it's a moment of misery. How many are you creating on a daily basis? I know that you're not a regulator. I know you're not on radio. But giving superior customer experiences is one way of getting them to your side and not going to the quacks. Please, am I making sense? All right. Communication strategies for patient safety. Clear patient communication is clinical competency and a safety imperative. Plain language, informed consent as education, post-treatment follow-up, and clear feedback channels so they tell us how well we did. You see, the more we keep them comfortable, the more they'll keep coming back to us. So all these things I'm describing is about making the patient safe by making them secure in the relationship with you. That's how you keep them on your side. Sir, please, are you with me? All right. So, do you have a Ghana Dental Council? And medical is inside. And that's what I was asking you. Okay. So I think they are part of it because their name also came up on the stage. They are very powerful people. Then, who is that? I'm suspecting the school they went to. Okay, all right. Okay. You guys are at the top. Media houses are there. We have legislation. The regulators, I think they need legislative support to do things fast. And then civil society. So this is my closing framework. And I think that if we have good collaboration around these 5 actors, the grace of God will be available. You know, 5 stands for grace. So I think the people, they are also 5. So as I end, my prayer for you is that God will grant you. Oh, sorry. Okay, I'm coming. Some of you were photographing this. Okay. So this is it for me. This is a framework I'm proposing. I don't know whether it will work on, but my job is to explain from a practitioner standpoint that practically I think this is where the collaborative power should lie. The reason for putting you guys at the top is that in Ghana, things don't move when you talk about them and go home. Things move when, after a session like this, some collaborative paper is written with suggestions regarding how we should take it forward and supply to all these partners, and a call for a first meeting to be had to see whether a multi-stakeholder coalition can be created. Ghana, we talk too much. We write little, we move little. That should not be our portion. Habakkuk 2:2 is clear. Write it down. Make it plain. When they see it, they'll run. Stop talking and write. That's my humble proposal to you as I end. Okay. So here is what it is, Dr. Holy Child. This is what success will look like in my humble estimation. If a year from today, we can get a national practitioner verification system launched, it will be a blessing. If it's not already, then we're on our way. If we can get solid media partnership established, 3 major campaigns aired, and the spirit of the 3 major campaigns is that it's 1 a quarter. So if we can sort of do 1 a quarter and then have clear, and the thing with campaigns is that you must always have baseline data, so that when you deploy the campaign, you have data you can measure the success against. So you do a baseline, then every quarter you do a tracker. When you do the tracker, you have data for the next campaign cycle. So that's how you do successful campaign. Not just finding people and talking. No. You must have baseline data to ascertain the scope of the problem today. So that when the intervention comes, you can do trackers over time. Year 2, Madam President, we want a 50% increase in Quackery reports received. Again, there must be a baseline for you to be able to ascertain 50% have come. Mobile dental unit deployed in 3 regions. You need resources. You might need a donor. You might need a big corporate entity. You need resources. School health program piloted in 100 schools. Can be secondary, it can be tertiary, it can be what, just conceptualize it. Year 3, measurable increase in patient trust scores. Again, there must be a baseline. 30% reduction in reported quackery policy recommendation. So you see, by year 3, legislation is kicking in to throw out the quacks once and for all so that we will not see them again. That's Exodus 14:13. Remember, some parliamentarian went to use it against somebody, became a whole fight. These Egyptians you said today, tomorrow you shall see. It became a major fight in parliament. Exodus 14:13. Okay, year 5. Ghana recognized as a model for what a lofty ambition. That if 5 years from now we become like a West African typology of anti-quackery, oh man, that would be a blessing. And then licensing verification will be integrated into national health insurance. These are very utopian goals. But if I've learned anything at all in life, this is what it is. It's better to have audacious, impossible goals than to be mediocre and not get anywhere. I got to the University of Ghana at 29 years, and I said, by 40, I'll be professor. I was professor by 40. It is what it is. So you better set the high goal. Don't be walking around and talking. Set the high goals, get the systems moving, trust God for progress. Victory will be yours in Jesus' name. Say amen. I am done. God bless you. Bye. You can't go wrong. I didn't even see that you have insulted me already. I'm not happy with me.
Please, another round of applause for him. So like Accra Hinson has rightly said, I think, Madam Chair, with your permission, and I'm sure maybe our GA will deliberate about this, I think it won't be a bad idea at all to have this topic again next year. He has written the vision, he has given us the slides. Now it is left with us to run with it. So I think our work has been cut out for us, and we want to say a very big thank you to Accra Prof. Hinson for this. Please, because he has another engagement somewhere, can we quickly take 5 questions? I think there's one question asking if, with your permission, if the slides can be made available.
Oh, they can be shared everywhere in the world. Oh, no problem.
Okay, thank you very much.
Fantastic. Yes, please.
Please, there's a question at the back.
Yes, please. At this adult college. Fantastic. At this adult college. Yes, please. Santa Clausian. I can hear you, sir. Yes, please.
I'd like to know why you singled me out.
You have very distinctive features. I mean, there's no silver fox on your row. So you light up the room. So many congratulations, sir. You are an amazing silver fox. Well done. So how many? Look, there's no, let me see. The whole room. You are the only silver fox. So well done, sir. And your pochette is also pink and popping. Congratulations, sir. Well done. Yeah. Is there anybody who went to Presec? Is there a Presecant here? He went to Presbyterian. There's Ogasco here. Absu. Yeah, Absu. Presec. Oh, okay. All right. Please, what are your thoughts? Sixth Form Science College. What are you thinking about in Presec regarding the presentation? Will it work? Or it's not too audacious? It will work. Amen. Anybody else? Is there any Wesley girls here? Already you are not happy with me, but I'm just calling you still. Wesley girls. No Wesley girls. Hey, madam, it's good to see you. How are you keeping? Oh, very good to see you. I didn't see you. I didn't see you. Oh. So where's Richard? Richard should have been on this line. Why didn't you bring Richard? I guess she'll come tomorrow. Oh, congratulations. Wesley girls is here. Okay. Once I've seen you, I'm full. But Ogasco Putu are here. Congratulations. So there's Gehe, Ogasco, Adisco, Achimota. I think, is that Mauli School? Mauli School. It's also a school. Mauli School. Maoli School. It's Maoli School here. Or yeah, Maoli School. Yes, please. Yes, please. Clap for him. Yeah, ambassador with fees.
And I think maybe the maxillofacial surgeons will also make you an honorary
yes, well, the maxillofacial
surgeon.
people. I like you people too much. Maxillofacial. No, I'll never forget that word. In fact, I'm going to post it this evening. Maxillofacial. Do you know what this is? I'll write it everywhere. Maxillofacial. No, I'll use it when I get to the hotel. Hey, do you know maxillofacial? Yes, those who answer will win. Please, are you okay? Please, I'll leave with one scripture from John 1:16 from the ESV. It says, "For from his fullness we have all received grace upon grace." So I pray for you that in your dental practice, God's grace will be available to you. And that in spite of any challenges you are confronted with, it will end well. In Jesus' name. Amen.
Amen.
Holy child, I'm awful. Gotta run. I'm never late, so I have to run. You have to present me something.
Just before you go, please.
Wow, it's too powerful. You see, this
so
is
please call on
this
Madam
is the
President.
correct photograph, not the other one. Prisa, can I come to the presentation? Or the Holy Child people are coming? It is what it is. Okay. Told my wife to come and support
Madam
me.
President, please.
This thing broke, so please, you can throw it away from me. Achimota School. My goodness.
So, Prof.
You. Amen. You see? It works.
So, Prof. Robert Hinson.
Yes, please.
Accra, Prof.
Say it well.
Robert Hinson.
That is it.
You yate. Black and white, but you are not in black and white.
No, she wore it for us. Look at her.
And your shoe is black and white.
By the grace of God. Yes.
On behalf of the Ghana Dental Association, we thank you and we appreciate.
Thank you very much.
Please, let them send me your number so I can say hello to you.
Okay. So please, another round of applause as our honorary maxillofacial specialist leaves us. Our next speaker is Dr. Emmanuel Morris Accra. He will be speaking on the topic ethics and professionalism. Dr. Emmanuel Morris Accra is one of Ghana's foremost medical legal practitioners. He brings to the bar a rare convergence of clinical expertise and legal acumen that has defined his distinguished career. He's a trained medical doctor and an enrolled barrister at law. These credentials place him in a select group of professionals equipped to navigate the increasingly complex interface between healthcare delivery and legal accountability in Ghana. For over a decade, Dr. Accra served at the helm of the medical legal unit of the Ghana Health Service, an institution shaping tenure during which he became the authoritative voice on medical liability, patient rights, healthcare governance, and institutional risk management with Ghana's public health sector. His leadership of that unit was instrumental in defining how the state approaches clinical negligence, professional discipline, and the legal obligations of healthcare providers across the country. Beyond the corridors of public service, Dr. Accra has maintained an active courtroom practice across various areas of the law. His dual qualification enables him to interrogate clinical evidence with the rigor of a clinician and present it with the persuasion of an advocate, a combination that remains exceptionally rare at the Ghanaian bar. Dr. Accra is the managing partner and head of the medical legal division of A.E.K. Kojo and Associates, legal practitioners and notary public in Laboni, where he oversees the firm's advisory and litigation practice across clinical negligence, patients' rights, health sector regulatory compliance, and institutional governance. He has delivered professional legal education to clinical staff at several of Ghana's foremost teaching hospitals, including Kolebu Teaching Hospital, Konfanoche Teaching Hospital, Tamale Teaching Hospital, and the University of Ghana Medical Center, among others. He's a sought-after speaker and commentator on health law and professional liability. Dr. Ankra's insights are grounded in over 2 decades of frontline experience straddling medicine and law. He brings to every engagement not only the depth of a seasoned legal practitioner, but the unique perspective of a clinician who understands from both sides of the examination room what is truly at stake when professional duty meets human life. Let's please kindly welcome Dr. Emmanuel Morris Ankra.
Good afternoon, everybody. When my father's profile was being read, I said, wow, how am I going to do this? The letter will say that I've been sent by my father, so take it easy on me. Madam President is actually my dentist, so you'll be seeing a lot of my teeth today, so you know the good work she's doing in my mouth. And Madam President, I'm feeling very heavy shoes. So please encourage your people to nod and smile, because my boss and my father are supervising me today. So today, I think Prof. Henson has done a very good job. I'm just here to spread and sprinkle a bit of legalese on the topic that Prof spoke about. So today, Dr. Ankra has put together a very nice PowerPoint. He's titled it Ethics and Professionalism in a Competitive Digital Age. So, permission to carry on. Thank you. All right. So, we are now in a digital age, and everything is governed by marketing, especially in the medical field, because I deem it that this topic was taken because we are now seeing a lot of practitioners, whether fake or real, using digital platforms to promote their work. So the head of the slide is every marketing decision is also a clinical and legal act. Whatever decision you decide to take in marketing yourselves or in promoting your dental expertise, you should know that is also a clinical and legal act, and you are governed and you are bound by certain ethics and certain codes. So if we take, for example, 2 acts, one that has been done by a quack doctor and one that has been done by very distinguished doctors like you, the first thing the patient sees is a brand and a promise. So you say, my teeth are looking gold, but when I come to you, my teeth will be white as snow. The patient has taken it as a promise that by the time I'm leaving here, when I smile, there will be a reflection, I'll blind the whole place. But you, as the medical expert, you should always remember that you are bound by professional ethics. You are supposed to be registered. The work you're doing is supposed to be governed and bound by professional codes. Now, I speak of professional codes and I speak of ethics. We have certain regulations in Ghana and in the international space that govern your work. So in Ghana, we have the Health Professions Regulatory Act, which more or less is the authoritative book or law that governs health professions in this country, which is Act 857. We also have the jurisdiction of the Medical and Dental Council, which is revered by a lot of medical practitioners in this country. When we come to the office and they say, the Medical and Dental Council says I should come, then it is all haywire. It's all, would they take my license? What am I going to do? Can I practice again? So all these things should guide you, and when you are interacting or marketing yourselves in a digital age. Now, you should always take yourselves as a sacrificial lamb, because whatever you do, a patient will complain. So you just have to make sure that in the forefront of your mind, you are doing what is right. Now, this is actually talking about the fact that the quack shouts, the professional is bound, like I've already said. The quack is an unregulated provider. They are not bound by any rules. They are not bound by any ethics. They can do what they want to do. You go on social media, and they are using AI tools to make teeth look very unprecedented. And then you professionals see it, and you're like, this is not possible. But they are doing it either way. So what are you doing about that? So the unregulated provider has no license. It's not registered. It's loud. Gives unconscionable promises. There's no accountability when harm follows. And they are competing with noise. But you, as clinicians, you are bound by Act 857. You have the Medical and Dental Council on your throat. Your claims, whatever you say in the bounds of your practice must be true. You are also answerable to conducts that you take. And then you compete on trust. When I say you compete on trust, I'm saying that you are not competing based on whose lighting is better in the hospital or whose smiles better when the patient comes in. But when the patient walks in and they are leaving, they must be able to say that, oh, this doctor, I like them, based on the professional act that you have, service that you have given to them. So trust in the dentist is the dentist's true currency. Ethics is how you mint it. Do not retreat into invisibility, and do not imitate the quack. Win on trust. Forget the quacks and stay in your ethical bounds. Now, we have 4 layers that govern your work. We have statutes, we have the regulator, we have professional codes, and we have global standards. I've already spoken about statutes. I've mentioned the regulator. I've spoken about professional codes. So we have, when we say professional codes, we have codes like the American Dental Council. We have the General Dental Council, which are all for a persuasive effect. That's where there's a shortfall in the Ghanaian law. These ones can also guide you. We have global standards like the WHO, which have also outlined certain actions to govern the dental practice in this country. Now, this is my favorite slide of all the slides. And I want you to take a look at these 6 anchors and let it sink in before I continue. Now, this succinctly put, when we are going for graduation, when we are doing after 6 years, they give you the gown, they give you the robe, everybody's so excited. At that point, I can say that 95% of the people sitting down do not remember anything that was said, because it's all excitement. But the most important thing that you do in that room is taking the Hippocratic Oath. If I'm to come down right now and I go around and I ask, how many of you be able to tell me what was said, what the Hippocratic Oath is? Word for word, verbatim, verbatim. So this is what should be at the forefront of your mind. Beneficence, non-maleficence, veracity, respect of autonomy, professional integrity, and legal compliance. Whatever you do in your field, once you are anchored in these 6 things, you are good to go. Once you come to the office and Dr. Ankra sees you and he asks you a lot of questions bound by these ethic anchors and you take them, you'll be fine. Advertising rules and real-world practice. You may advertise, but you may not mislead. Like I said, the quacks or the fakes are allowed to say whatever they want to say because they are not bound by any professional code or ethic. But you, there are always eyes on you. the threshold with which you are held to is different from what a quack is held to. So we can say that you are permitted. These are the things you are permitted to do. Give factual, evidence-based information. When you are answering a question, when you are going on talk shows, and you are going your capacity as a professional, you should make sure that whatever answer you are giving can be verified. Don't say things out of excitement, or don't hide under the umbrella of, I'm a doctor, whatever I say, they'll believe. Because now the Ghanaian mind and the lay person is now opening, or they are averting their minds to litigation. It is now a new way of making money in Ghana. You go to the hospital, the doctor coughs in the wrong way, they say, Dr. Wanade, I'm going to see my lawyer. So whatever you say, you should make sure that it's factual and it's evidence-based. Your qualifications must be genuine, and your services as such. Clearly state your fees and your terms. You are allowed to do that. You are in the business to make money. Maybe some of you run an NGO, that's fine. When I'm going, I'll take all those locations so that, President, I'm not leaving you, but it's cheaper elsewhere, so I'll go to the NGOs. There's also patient and public oral health education, which is very important. That's why we are here. When I was sitting down, I was having a conversation with my colleague and Dr. Ankra about the fact that dentists do not speak up. You never hear of the dentists complaining. It's always the physicians. When there's a problem in the health sector, dentists are quiet. I don't know why. But you have the power under the law, under the fact that you are a qualified dentist to give oral health education. Now, the things you are prohibited to do, you are not allowed to do them, is to say that you are the best. You do a billboard, you say, I'm the best dentist in Ghana, come to me. It's not allowed. You can't compare yourselves to colleagues. And like I said, your best marketing strategy is trust. Once you build the trust of the Ghanaian people, of your patients, there's a simple saying in Ghana that there's no need for you to compare yourself to other people, solicit other people's clients, claims, and raise claims that are unjustified. Like I said, by the time you are leaving my hospital, your teeth will be white as the tablecloth. You are not allowed to say that. Let's move on. So now we are balancing professionalism with visibility. Now, don't hide, like I just mentioned, dentists are very quiet. Inform, but don't entice. Don't hide from patients that need you. And that's why the quacks have seen that there's a lacuna. The dentists are not doing it, so we'll do it for them. And there's a term that we, the young ones, use, or I'll say Gen Zs. We call it settings. The quack doctors are doing the settings, and the real professionals are quiet. When you're doing advertisements, the first thing that catches the eye is the storyline, the colors. We have, Prof. Henson mentioned influencers. I don't know who they are influencing, but not me. But they claim to be influencing people. So the quacks are utilizing the tools that are available to them. But we are still sticking to the traditional ways. And the school I went to, our main motto is Jane Shekan. I had talks about innovation. Yes, in Fanspim School. I'm a mobile. Are there any mobiles here? Thank you, Senior Mobile. Thank you so much. So, Jane Shekan, think and look ahead. Right? Presence is legitimate and it's encouraged. So, use it. Use the tools available to you in the bounds of your ethics. Do not compete with the quacks. When the quacks are shouting, maintain your composure and your work will speak for you. Represent yourself in a way that adds esteem to the profession. This is one of the ethic codes from the American Dental Association. Moving on. Social media presence and professional image. Be a trusted voice, not a salesman. Yes, you are running a business. You consider yourself to be marketing your business, but still, be that trusted voice that when you speak, your own colleagues say that, oh, yes, he was my mate in school. He's speaking the truth. So speak in a way or advertise or build a professional image that lifts the profession, that takes into consideration consent, confidentiality, disclose every connection. If you are using influencers, if you have ties to any person that is outside of your scope of work, it's not a qualified practitioner, but you are using them to promote your business, make sure that you disclose the person and the capacity in which they are working for you. Because people tend to be very naive and take the word of people line, hook, and sinker. And at the end of the day, you will be held accountable because we call something in law vicarious liability. You are the employer, that is supposedly your employee. So any act done by your employee, you'll be held responsible for that act. So let's be careful when, especially, we are engaging people that are outside of our scope. Let me go back. Counter misinformation, very important. Do not be afraid to comment on a post. Once you are sure, if you are not sure, contact other dentists. Ask them, oh, do you remember this? What did they say in school? XYZ, do you think that this is right for me to post? What do you think? Put it on the platform. Once you are sure, you have 3, 4, 5 people saying the same thing, and you are bound, again, by your ethics and code. Please counter that misinformation. Because as a layman, today I'm here as a lawyer, I'm not a dentist. So if I go on social media and the settings is right, the camera is right, and the teeth is looking like the tablecloth, I'll go there. But you have the responsibility to come and say, no, this is not what it is in reality. And then we are all desensitized from quacks. Managing online reviews and patient feedback. Reviews are testimonials, and testimonials are advertising. So the review of the work you've done is a way of the patients advertising you. So we go on social media. I see that my teeth was gold. Now my teeth is looking white. I go on X. I say XYZ is the best dental clinic in Ghana. That's advertising. That is your trust that you've built working for you. Like I said again, disclose connections. Confidentiality survives a bad review. This is also very important. Never confirm, even implicitly, that a complainant is your patient. Do not argue clinical facts in public. Do not engage in a back and forth with the patient. If you see a bad review, keep quiet. You are not bound to respond to everything. The person is a layman, and in the jungle, the laws do not conform. Everybody says what they want to say, and the loudest is who wins. So maintain your composure and make sure that whatever, again, you are communicating is in the bounds of your code. Ethical patient attraction strategies. So attract value, but not inducement. So educate and serve. Transparency and consent. Consent is very, very key. Sometimes we as professionals think that we know. So when the patient or the client comes in, we don't even allow them to talk. Oh, doctor, my head is paining me. Okay, yes, so take XYZ. Oh, no, doctor, I don't like this. No, I'm the professional, I'm telling you. No. Make sure that you always have the clear and informed consent. Informed consent is where you have told the patient all they need to know about what is wrong with them, and they make a decision for their own. Competition from unregulated providers. So this is also very important. Now, the law in Act 857, which is the Health Professions Regulatory Act, criminalizes certain acts. So Section 30, for example, and when you go back, please, everybody should grab a copy of Act 857 and read it for yourselves. It helps you in making decisions and rethinking things that you do. And you know that the law works when something happens. So Section 30 talks about the fact that no person may practice medicine or dentistry unless registered with the council. Unregistered practice is unlawful. When you see the quacks, report them, educate the public. Do not imitate the tactics they are using. Always remember that you are bound by ethics and by code. Section 48 now criminalizes people who engage unregistered practitioners. So when you report both the fake and the person patronizing the fake, the law will hold your neck. Maintaining integrity while growing a practice. So the fact that you are growing a practice, sometimes when the demand gets high, you start to find loopholes, you start to find shortcuts. When your clients were 2, you do everything pe. Now the clients are 50. Now you start to feel like you can cut corners. Please do not do that. Building trust in a competitive health market. Like I said, you build trust by being competent, by being honest, by being consistent, and by being accountable. There's a short note under. The registered professional's unfair advantage is verifiable trust. A name on the MDC register, a reputation that compounds with every honest interaction. The quack can copy your advert. They cannot copy your accountability. So if you don't take anything today, just remember that the quack can copy your advert, but they can't copy your accountability. Before you post or publish, ask yourself these 6 questions. Is it true and evidence-based? Does it respect consent and confidentiality? Would it survive the MDC disciplinary committee? Can I substantiate every claim? Does it inform a choice, not manufacture a desire? Does it lift the profession? As you can see, these questions are still in the framework of your ethical prospects and what you are guided by in your field. If the answer to any of this is no, do not publish. Like I said, I gave an example. If you are unsure, put it on your platform, put it on your pages, ask your friends questions. This thing I'm saying, is it true? This is what I remember that they taught us. Maybe the position has changed. There's been different standards that have been set for whitening teeth or doing braces. Before you go and post, ask. There's no harm in asking and verifying from your colleagues. What a post can do. So 2 roads from the same post. One post can cause you an MDC complaint and disciplinary proceedings, can cause you a reprimand, can cause you a fine, expose you to civil liability. That same post can build your reputation, builds patient loyalty, and there's a durable advantage over unregistered provider. Now, this one, we'll do it together. This is for the people who are pressing their phones, who fell asleep, those who are thinking about the money that they are losing out for sitting here. So we'll take the first one together. We'll all say it together. We'll read through all of them together. So if you do not take anything home, this is what you are taking home today. So 1, 2, 3, go. Ethics is not the brake on growth. It is the engine of trust. I can't hear you. Let's do better the second one, please. Madam President, please encourage your people. I told you my boss is here. Thank you very much. You may be visible. You may not be misleading. Consent and confidentiality are non-negotiable, online included. This one, let's loud it, because there are media people here. It's going beyond us. 1, 2, 3, go. Quackery is unlawful. Report it. Never imitate it. Trust compounds. Build the practice on it. And to end, just to say that restoring trust is the marketing strategy. If we are complaining about quacks, the only way we can bring back the love, as we've done for the Black Stars, is to make sure that we bring also back the trust in the dental space. And like I've said, from here on out, I want to see more professionals, more of our seniors in the field speaking up. Speaking up is not a wrong thing. Like I said, just make sure that the information you are putting out is verifiable and is bound by ethics. The questions and answers will be taken by my boss and my father, Dr. Ankra. Thank you so much.
Okay, thank you very much. Okay, so before the questions come, a few highlights from his presentation. One thing he said that stuck with me was every marketing decision is also a clinical and a legal act. I think for us as professionals in the field, we have to keep this at the back of our minds. Another thing he said was that the quack shouts, but the professional is bound, okay? So in this our battle against quackery, we still have to be within the ethics of the profession. I have a question. One of my questions from the previous speaker, the regulator, I don't think he came to meet him. In introducing ourselves, or now if you want to make social media marketing, you want to introduce yourself and your practice, are you allowed to say maybe my name is Dr. Goka, I'm senior specialist at this, and then put it out there in the public? Does that constitute unfair advantage over other practitioners who might not have reached that grade?
No, not per se. Introducing yourself itself does not constitute taking advantage. But what follows that introduction is the matter. You know, we've been made to understand previously that clinics, hospitals, and dental practices are not supposed to advertise. But that is not the case. The case is simply that the hospital and the clinics are like any other business. The hospital can advertise, the clinic can advertise, but the practitioner cannot advertise himself or herself. The clinic that you've taken loan to open, to buy equipment, has every right, like any other business, to advertise. But the practitioner, so you should be able to distinguish the two. Who is advertising? And don't allow your name to be used for that advert, because you are regulated by Medical and Dental Council. The clinic is like any other business. But the practitioner is not like any other businessman. The practitioner cannot use his qualification for adverts.
Okay.
The services of that clinic, you must be able to advertise that you can do A, B, C, D, E in this hospital, in this clinic, in this facility. That is normal. There's nothing wrong with that. But you don't go ahead and say that because Dr. So and so is here, we can do A, B, C, D. That's the difference.
So if I get what you're saying correctly, maybe I can, if we had a hospital Instagram page, we can maybe say, I work in Ho Teaching Hospital, so we can probably say dental department, Ho Teaching Hospital, we offer oral and maxillofacial surgery, we offer implantology, we offer this, we offer that. But we can't say we have maybe a head specialist in maxillofacial surgery, maybe Dr.
You can
Ato.
say that you have these kinds of specialists or specialties in the hospital or clinic, but
Okay.
you can't attach names.
Okay. Even if it's a private clinic?
Yes.
Okay. Okay.
It's a specialist clinic. We offer so and so we have this kind of specialists who come and consult. It is normal to say it so that the client will know and come. But you cannot say because Dr. A comes, Dr. B. No, that is advertising particular practitioners, and that practitioners will be answerable to Medical and Dental Council.
Okay, thank you very much. Please, the floor is open to any questions, please.
Please ask. The clock is ticking.
There are two questions. Please, we take Dr. Ankwa first, and then I can't see the person well at the back.
Yeah, thank you. This is very interesting and insightful to some of us regarding advertisement. May I find out from you, are there any regulations governing the size of the advert if the practitioner's name would not appear on it? Are there regulations on that? Or you could get a billboard as long as the name of the practitioner is not there on it. You could do that. Thank you.
As I said, the hospital or the clinic is like any other business. The practitioner is not like any other businessman. So that is the difference. It used to be, you know, we used to have an NLCD 72. That was passed long time ago. And in that, they had stated the size of the billboard, which is like a toolbox, very small. And in those years, we had few practitioners. So you see the practitioner's name, very small written, hidden somewhere. One-man clinic. Today, as we are speaking, you cannot find a single clinic that is run by one man. And therefore, there is no need even to add anyone's name. It is a clinic. It's a business. It's a business. And it may interest you to know that there are some clinics that are manned by non-practitioners. It is theirs, but they've paid people, employed people, and used their name to register. And therefore, why would they put your name on their advert or signpost? They may sack you tomorrow and get another person. So in real sense, there is no need putting a name on that billboard to cause any problem for you. And you have the liberty for any size, any color. Because it's a business like any other business. The ethics is bound by the professional. But I haven't seen HIFRA asking any pharmacy or any lab about the size of their billboard. HIFRA is the one regulating the facility. Let's get it clear. I was here when they were telling you, HIFRA is regulating the facility, and the billboard is for the facility. Medical and Dental Council has no business with that facility and the billboard. They have business with the practitioner. Are we on the same page? The hospital, the facility, is regulated by HIFRA, and they regulate the pharmaceutical company, the pharmacies. They regulate the labs. I know you've seen their billboards, the labs, their billboards, and the pharmacies. You see their billboards. You don't see pharmacist's name on that billboard. Is that right? Yes, because that pharmacy is a business. Likewise, the hospital is a business. So why do you want to put your name on that billboard? If you put your name, you are looking for trouble.
Okay. Dr.
Hello.
Tamam. Yes.
Okay. Since we are mandated to educate the public because we are clinicians, I would like to know if the law gives us some protection, because against, talking about quacks. Sometimes when you engage them on social media, you are warned, they threaten you and so forth. So I would like to know if the law gives us some protection.
Yes, you are
Thank you.
protected by law. When you are threatened, it's a very serious matter. Don't take it lightly. Threat of harm is a felony. It's a higher offense. So please report these matters to the police, and you are protected. And the person threatening you can be traced. Now, if you go to the cyber crime unit, just show them your phone. They can trace the person, arrest the person, and then they take it from there. So don't take it lightly. And it is our duty to do that. It is our duty to do that. When you confront them, sometimes they are very hostile. But when they know that you know what you are talking about, they find a way that would draw the advert or whatever they are doing and close down the place. I've done it, and the person closed down the place and disappeared. Because I called him to refund the money to the client, and he did it. And I told him, I didn't meet him, I told him, close down the place because I'll be watching. And he closed down the place. Whether his lease had expired or not, it's neither here nor there. Close down the place and disappear. Because you are not a registered practitioner.
Okay. We take one question, yes, please.
Yeah, Dr. Governor. I think let's go back to the issue of advertisement.
Yes, yes.
I think we limited the discussion on billboard, like what Dr. Ankra was asking about earlier. But I think advertisement goes beyond only putting things, billboards on your premises, because we have the radio and the TV also there. So I think we need more clarification on that.
Okay. Yes. Just as she said that she has been invited on the radio, but you know that some practitioners also pay journalists to invite them to have a space so that they could magnify their practice. And in that sense, if they go, and as I said, introducing yourself is not a problem. What you say on radio, tele, when you have invited, even invited, what you say is the most important thing. What you say is the most important thing. That will be used to, the measure will be there. Whether you are advertising, trying to take undue advantage, is what will determine whether you are guilty or not. By just introducing yourself as working, I think, at Whole Teaching Hospital, and saying that they have this kind of services at their dental unit, there's nothing wrong with that. It's pure public education.
Yeah, but the issue may not be necessarily you going to a radio or TV station. You could pay for advertisement
to be published.
To be published on the TV or radio station.
With your name.
Not the name. It will be the name of the facility. You are not putting your name there. But it's A&B Dental or A&C Dental Clinic. We are the best. We offer ABCD.
Yes,
us,
that is normal.
That is
we offer ABCD. That is normal. That is normal. The person is saying that, please, if you don't know, there's a clinic here called ABC Dental Clinic. These are the services you can't find there. They offer. They haven't done anything wrong.
Hey, are we sure?
If they go ahead to say we have Dr. ABCD who are coming to offer this kind of services, then they are advertising those doctors, and those doctors will be liable. So if they don't tell them that they have a clinic here and that these are the kind of services they offer, how can anyone know? And that is why we said that don't be invisible. Be visible within the boundary. You see, and I can understand where you are coming from. The old school were made to understand that even mentioning the name of the clinic on radio is a sin. It's an advert. But I haven't said Dr. Ankra's clinic is the best in town because Dr. Ankra is working there. I offer ABCD, so come to me. If I do that, I'm advertising myself. And therefore, I'm answerable to Medical and Dental Council. But if I say that Clinic A offers ABCD, excellent services, client-oriented, so and so, why not?
I'm saying this from personal experience because I have a private dental clinic. On many occasions, these TV stations and radio stations approached me where they want to come into that partnership or where they want you to pay some money. They call it like mentioning whatever, like when they are doing their programs, your clinic can be mentioned
It is
parts.
normal. Like this program, if somebody, a clinic owner paid, and they are talking about sponsors, that clinic must be shown. Sponsored. Whether they paid 50,000, front page, 10,000, sideways. So it is normal. It is normal.
Please, can we bring the mic to the front, Dr. Owusu? We'll take 2 more questions after Dr. Owusu's question and we'll be done.
Thank you, Dr. Ankra. I think your point on the distinction between the practitioner and the practice is clear. What I want to know, though, is can you have images of the practitioner on a signpost without the person's name? Is that also correct? Or in the advert?
If the person can be identified, listen carefully.
I'm wearing face mask.
And why do you want to go through that when you could have used any other image and remove yourself from the harm or the problem? It's very simple.
So in that same vein, if it's on a website, is that also of the law? There's a and it has my image on it as well.
What I'm saying is that the practitioner is bound by the Medical and Dental Council rules not to advertise himself. I'm coming. And I'm saying that the practice is not bound by Medical and Dental Council. The practice is like any other business. The clinic is not different from the lab. Look at their billboards. They are on radio. Look at the labs. Look at the pharmacies. They are all advertising. The difference is that they don't mention any practitioner's name. They mention the services. And we must learn from that and toe that line and stop this our old school thinking. Your image may not add anything to the advert, but may cause you so much harm.
Okay, can we take a question from the back, please?
Okay. I have 2 questions from those watching online and 1 personal question. So the first question is, what is the regulation or ethics of practitioners featuring in adverts for their facilities?
I think we've covered that, right?
It has been covered?
Practitioners featuring an advert for their facilities.
Yes, please.
I think I said practitioner is not supposed to advertise.
What if the clinic is taking a video and then the practitioner is there working? Is it the same thing? I'm just asking for those online.
And you see, it says something about confidentiality. That practitioner ought to agree that his image will be published. So if you agreed and your image is published, you cannot come back to say that you didn't know anything about it. I hope you understand. A practitioner, nobody in the clinic or the hospital can publish your image without your consent. So if you agreed, you consented to publication, to advertise you, then you knew what you were doing, and you knew the place you are placing yourself.
Okay. And one last one, sorry, please. So this new generation, there are a lot of content creators, like dental content creators. Let's say a dental content creator is doing an educational post, and then in that content they say, oh, you need to go and visit your dentist, or come and see me, I'll do this and this for you. Is that one to...
Come and see me, meaning who? You are a doctor content creator.
On social media.
And
on
the
social,
doctor...
I'm coming. You are a doctor content creator. And you are saying that they should come and see you. And you think you are not advertising yourself. It is straight advertisement.
Interesting.
You see, educating the public is different from advertising yourself. And I'm telling you that some people hide behind that. They are paying journalists and radio presenters and TV presenters to bring them so that in trying to educate the public, they will take advantage and market themselves. And that's the danger.
Can we have the last question from Dr. Drea?
Thank you. Dr. Ankra, please, I don't know if something has changed, but what you are telling us right now is it's always been a medical practitioner cannot advertise. I've known that. And there's this particular clause in the MDC, I don't know if it's Code of Ethics or Code of Conduct. When you finish school, they give you. It even stipulates the dimension of your signpost and all that. But now you are saying we can advertise the clinic without our names.
I'm saying that Medical and Dental Council cannot regulate a hospital or a clinic.
That clause is there.
Listen, let's take it step by step. You see, sometimes they overreach what the law permits them to do. Medical, today, if you don't know, I'm telling you, Medical and Dental Council has no right to tell a hospital how to operate. They can tell a practitioner what to do. When they enter a facility, what they can do is to arrest a practitioner. The hospital is regulated by HIFRA, also by law, by parliament. Can you imagine HIFRA going around and arresting doctors?
That's why we don't advertise, because I've
Very
never
good.
had to.
So when they cross, and you know what you know, you just smile and let them be.
Okay. Please, in 30 seconds, our very last
Because
question from
I don't
Dr.
see how
Aramide.
they can oppress clinicians and the clinics and allow pharmacies, labs, the same regulator, and tell one to do advert like Mapam and the other one the whole room, competing for the same clients. It's not going to
Please,
happen.
can we pass the mic, Dr. Aramide, then Dr. Razak? Then we are done,
Hi.
please.
Thank you. So I would like to ask about the regulations around endorsement of healthcare products. So healthcare products. So for instance, if Colgate approaches you as an art.
Maybe like.
So for example, if Colgate approaches you as a dentist and asks you to endorse their products, I would like to know the regulations around that.
Yes, you see, if you look at Medical and Dental Council regulations, they will tell you that if you are doing it for a fee and you are doing it for an advantage as a practitioner, it is not ethical. You see, you are endorsing one's product above the other using your profession. You know, if you talk about toothpaste, there are various ones. So if you endorse Pepsodent and I endorse Colgate and this one, what will be happening? The same profession endorsing different things, giving this different, saying that this one is the best, this one is the best. So what should the common man do? Let's be a bit, realistic.
Please, can we bring the
Those
mic to
things
the
can
front?
lead you into problems.
Dr. Razak.
Hello. But my question is, if I've seen a patient and I've treated the patient, for some reason the patient is not happy, and then the patient takes me to the media. For some reason, the media comes to me, put my image outside. They came to talk to me somehow, but somehow I found out that the media has put my picture and the kind of work I do in my hospital. Will I have a recourse of having them putting my license at risk?
They don't need even to put your picture before you can sue them for defamation. You don't need your picture before you can sue them for defamation. Just by granting that space for your name to be mentioned. You see, a friend of mine said that we were talking about the police. He said, Morris, do you know something? If your name is mentioned without your picture, many people will start calling you. But there are some people, they can even add their picture. No one knows them. So the point is, it's not about your picture. It's about your reputation that is being damaged. So you have a recourse to take them on. You see, the mere fact that that person is your patient doesn't mean I cannot sue that person for defamation. I hope you understand. Every one of us, we have the right to sue, to protect our image, our reputation, and our family, and our business. So don't take it that because you are a doctor and it's a patient, you can. The problem is you don't also mount the platform. You heard him saying it. You don't also mount radio station and start divulging the patient information. Confidentiality will catch you. The patient might have said A, B, C, D. Let it be. If you are not happy, you sue the patient for defamation in court. When you file the matter in court and it is published, they cannot sue you for breach of confidentiality. Listen carefully. When it becomes a court process and somehow it leaks, it's already out of your hand. It's a public information. But if you mount the platform because it said A, B, C, D, now I'm going to put the patient information so that the public will judge, you are breaching confidentiality. And that one, you have no excuse. So that is why he said the quack and others may shout, may make so much noise, but you are restrained.
Okay.
Thank you.
So on that note, please.
Listen, my worry is that if for some reason MDC says that they've seen me on the media with a tag of my name, Dr. This, does this way, will I have a defense?
Is that what?
If for some MDC picks me up,
yes,
that I have in a way advertised myself by providing that interview to the media house that I have put up information about the kind of work I do with my face on it. Will I have any recourse of defense?
If MDC will not accuse you and not give you the opportunity to defend yourself, MDC, they will write to you to respond, invite you to go through penal committee. Before, if you are not successful, you go through the disciplinary committee. It's a process. They don't just publish you. They don't just withdraw a license. Sometimes emotions may carry them, but when you know what you are doing and you step on the brake, the processes take its normal course.
Okay. On that note, please, let's give Dr. Ankra another round of applause. Please don't go yet.
Thank you.
So my closing remarks, I think from the two speakers, we can advertise our facilities. We shouldn't be the ones on the billboards, or our names shouldn't be on the flyers or whatever it is. Even if it's social media reels, it shouldn't be anything drawing attention to you, the practitioner. Attention should rather go to the facility. We thank you so much, Doc, for honoring our invitation.
The discussion is not yet over. We are going to continue. There's more to come. But we'll be taking a break. We'll come back after the break to continue. There is more to talk about. How to strengthen a legitimate dental practice and the other questions that are there to be answered. We also have our sponsors, Coral Dental, has something special for us. Unilever PLC has something special for us, and I'm sure you don't want to miss this afternoon's, the next batch after our break. We have one of our own, Dr. Yao Pebi, to engage us with another interesting discussion right after lunch. So before we break for lunch and come back in 45 minutes, I want to call on Mr. Vice President to do me the honors. Dr. Morris Accra and son. GDA appreciates your being with us and the knowledge shared. Receive our warmest thanks. Beryl. Dr. Ruby Yayira Goka for moderating our second scientific session explicitly and wonderfully. GDA appreciates your work. Thank you very much, Dr. Goka. May I please have, show by hands, anyone that doesn't have a coupon for lunch, be it lemon green or white. Show by hands if you don't have, because if you don't have it, you will not be admitted to the restaurant. So please see me if you don't. We will take a 40 minutes break. We are going for lunch. Lunch is at the restaurant. Just bypass the pool and take to your right. We will be back in 40 minutes. We will be back in 40 minutes. Strictly 40 minutes, please. So let's go there quickly and be back to continue with the exciting discussion. I'll see you shortly. Please also then let me tar in getting you back into the hall, please. You eat fast, enjoy yourself, have enough to fill yourself, but please, we are coming back just around 3:30. Just around 3:30, please. Just around 3:30. Let's be quick with that. Dr. Echampon's stand is also open for the demonstration of the implant. He has the stand out there. It's set and ready to see the guide, equipments and other things. Try your hands. Please do pass there also. But lunch should be over in 30 minutes and we'll be gathering here 3:35, please. 3:35 on the dot. See you shortly.